This paper is with 6 people. I'm not going to read all of their names. And the paper's on cognitive capacity, decision making, and medical diagnosis in the emergency department. So the paper kind of speaks to two literatures. The first literature that we're trying to add to is a literature that's broader kind of behavioral economics literature on cognitive load and the role that cognitive load or cognitive burden plays in decision making. In that space, there's a lot of prior work. A lot of it is theoretical. On the applied side, much of it is experimental. There are very few studies that look at these issues with kind of administrative data, especially kind of large scale granular administrative data. We're going to do that in this paper in the context of the emergency department at UCSF. And just to kind of set the stage, because I know we're in a room of health economists who have studied productivity variations in providers a lot in this room. This work is really going to zero in and focus on within physician changes in behavior as a function of underlying cognitive load. Okay. And so, the main approach is going to use fixed effects for providers. And I want you to be thinking of, Amy and the work she's going to do on a project on a day when she's kind of very tired and she's done many things already versus a day when she's super fresh. Okay, something like that. Overview of the data. We're going to use 2 years of high frequency data on activity in the UCSF emergency department. So this is going to be electronic health record data plus what we call audit log data, which you can think of as clickstream data for providers. So the key parts of the data we're going to use in this project are physician orders and results. So these are medical orders. We're going to be focusing in on diagnostic orders. So results physicians in the ED use to uncover a diagnosis or figure out what the right diagnosis for a patient is. And then in addition to that, we're going to have patient health information, patient characteristics, this Epic audit log clickstream data. And one of the key, very important aspects of our data set is that it's going to be timestamped to the second. That's really important because we're going to be measuring cognitive load or kind of cognitive burden in a fairly high frequency way. And so it's really important that this data is timestamped to the second. Within the context of cognitive load, which I'll talk about a little more, how we're thinking of that in a minute, the kind of core trade-off we're going to be thinking about in the paper today is a trade-off between what we think of as thinking and doing. So here, the way to think about this is when physicians are kind of producing healthcare for patients, obviously they're experts and they're doing a lot of thinking and assessing, okay, what's wrong with this patient, talking to the patient, figuring out what's going on with the patient. Part of that process, which you can think of them potentially like offloading to some extent to tests, is conducting external tests. So we're going to think about a relationship between physician thinking about the patient and physicians ordering external tests to get external kind of quantitative signals and how they use those things together under different states of cognitive burden. Okay. And so just to give kind of a quick overview of the methodology, just to level set before I get into the details, we're going to develop measures of cognitive load as a point in time measure. And you could do this in a number of ways, which we talk about in the paper. Here, we're going to be doing this based on the number of patients and the complexity of patients that you've seen within some recent time window as a physician. And so because there's a stochastic flow of patients into the emergency department, as people here know, that's going to create variation in both the number of patients and the complexity of patients that you're assigned to, that are assigned to you as a physician. And that we're going to use essentially as an instrument that's shifting this measure that we develop, okay? From an identification standpoint, there's really 2 things we're going to deal with. One is kind of the kind of quasi-random arrival of patients, which, obviously other papers have used from people in this room for the emergency department. But then also To develop these measures, we're going to be coming up with ex ante predictive measures of patient intensity, ex ante to the relationship to when the patient is assigned to the provider. That's very important because otherwise the kind of orders and notes and the diagnostic outcomes we're going to study would be endogenous to what's happening. Okay. With all of that setup in mind, we're then going to run regressions with provider fixed effects, and we're going to study the impact of these point-in-time cognitive load measures on a range of key behaviors and outcomes. The key things being all of these different kind of processes you're taking in the context of forming a diagnosis as a physician. Okay, we're not going to do full alert review. Sorry for everyone in the room. Really think of it as cognitive economics, complexity and rational and attention models. And then in health economics, there's many papers. Could not list all the relevant papers here, but look in the paper. Sorry, question. Yeah.
You mentioned about not using outcomes as part of the cognitive load. It's endogenous, but you could imagine some kind of outcomes, so residuals after controlling, or kind of an outcome where a patient unexpectedly coded or unexpectedly passed away. Is there any way to bring that in here?
Yeah, that's a good question. I'm gonna defer that for now because I think we've thought about it and it makes it a lot messier to do. But I know what you're talking about. You could try to use residual information from the ex post encounter. I agree. Okay, so in the paper we have kind of a fully developed model. I'm going to give you the highlights of this model just because I hope this helps helps to level set what we're thinking about with cognitive load and how we're thinking about this trade-off between thinking as a physician and doing with external tests. So the goal of the model is to develop comparative statics that we're going to then test empirically or measure empirically. And I'll have a table at the end of the section that kind of tells us what are all of these comparative statics. In this model, the physician faces a patient with unknown state X, which is the diagnosis we're trying to diagnose. They're going to have beliefs about this distribution f of x, and those beliefs are going to be gradually refined via signals. In our model, physicians are going to get two types of signals. One is going to be mental signals, which you can think of as thinking or kind of effort outside of external or diagnostic tests. And the other one is the diagnostic test or the external signals, which you can order. Then finally, you're going to choose what treatment to prescribe to the patient. In the timing in the model, the patient checks in and the physician is going to have prior knowledge based on intake information that they get in triage. The physician is going to contemplate and think. They're going to refine that distribution using these mental signals that they acquire. They're going to order tests, which is going to further refine that distribution. They're going to make a treatment decision. And part of that treatment decision is going to be not only medical treatment kind of on the spot, but it's also going to be, do we admit the patient to inpatient or we discharge them to home? That's going to be a key outcome that we're looking at. Okay, then the diagnosis X is going to be revealed, which is we're going to say is the final diagnosis we observe in our data. Obviously, we know sometimes that can be incorrect. Okay, this is the last model slide, but I wanted to give a little bit more of a sense here. And so when we kind of implement this in the paper, there's a whole space of potential diagnoses X. Under the assumptions we make in the model, they're going to be distributed uniformly. So think of kind of a course prior when the physician is approaching, but the patient. But this is a prior conditional on X's, which you can think of as a chief complaint. When the physician chooses to learn, they're going to acquire these signals. And in the model, signals are binary partitions that are partitioning the diagnosis space and refining the diagnosis space. One of the key things I wanted to mention is in the model, the marginal cost of mental signals, which you can also think of as mental effort, it follows this cost function Cm of Nm and L. And the L here is you can think of as kind of as the measure of cognitive load that we're going to be measuring empirically. And that's going to be convex both in the number of mental signals, or convex in effort, if you want a continuous version of that. And it's going to be increasing in L. Okay, so if you had a hard day already, and now you're seeing this patient, the marginal cost of exerting mental effort to treat this patient is going to be higher. Okay, the cost of external signals is going to be convex, so the cost of placing orders is going to be convex as well, but it's not going to depend on this cognitive load. this measure L, okay? Finally, the objective function, what treatment to prescribe, you're going to maximize the alignment of the treatment and your expectation is over the final diagnosis. The one thing to point out here is we also have A in this equation where A is a binary indicator of whether you're admitted to the hospital or not. So let me talk through this for a second. The absolute value of y minus x part, that's basically saying how well have you done with your diagnostic process? How close is your treatment y to what the final diagnosis x is going to be, okay? The A part for the admission part, that's saying, were you admitted or not? And the way to think about how that's included here is there's a cost of admitting a patient, okay? But that you're trading off that cost with error in diagnosis, right? So the idea is that if you're a physician and you discharge someone to home, but you're not sure, your treatment may not match the diagnosis. If you admit them to inpatient, it's going to match perfectly by the end of the encounter. That's the idea. Yeah. Yeah. Oh, sorry. No. It's not binary here. I'm wrong. Sorry. That's another version we have. This is the continuous version. Yeah, think of it as as the likelihood of admitting someone. Yeah. Sorry. Thank you for clarifying. Especially because in the slides that aren't here, we're then kind of optimizing with respect to that and showing the comparative static. So for this version, that's especially important. Thank you. In my defense, it's like 6 a.m. Pacific time. Okay, so last model slide before we get to the data. This is, instead of kind of running you through each result, I'm just going to tell you, these are the kind of comparative statics developed by the model. And the way to think of these comparative statics is what happens if cognitive load for the physician increases, okay, within a recent time window. And so what the model predicts is that the total number of diagnostic orders you place is going to go up. It predicts that the amount of common diagnostic orders you place is going to go up. It predicts that the rare diagnosis orders you place is going to go down. We then developed this empirical measure of entropy reduction, which is from information theory. And what this measure does is it just measures how much have beliefs been refined by the orders that you're placing, moving towards the final diagnoses. The model predicts that you're going to reduce entropy by less. So you're going to acquire less information in the initial orders you place. And then the implied prior from the initial orders you place implies that the thinking you did before those orders were placed is less informative. So acquiring less information. And then the model predicts that as cognitive load goes up, inpatient admissions are going to go up. So these are 5 things that we're going to look at empirically. And at the end of hopefully not the total end, but near the end of the talk, I'm going to fill in this last column with numbers. Okay. Yeah. Janet.
Talked about it. Sometimes it sounds like it's like cumulative over the whole day, and then saying it's in a short window, and maybe it's linear, maybe it's like quadratic or something. Like, doesn't it matter a lot what form it has?
Yeah, and I've been not necessarily. I've been vague because I've been talking about the model. When we get in a minute to the empirical stuff, you're going to see exactly what we're doing. And actually in the paper, we've done many versions of this, okay? So the main measure we're going to be developing is a recent 90-minute window relative to an index action you're taking with a given patient. But we have versions I'm going to tell you about where we look at kind of lags of that measure. And in all the specifications, we also have kind of aggregated measures from earlier in the shift. Sorry for not getting to that yet, but I'll get there soon.
I guess you could think about that as a type of cognitive ability, but it's not coming from the patients, it's coming from thinking about, what they're going to do.
Yeah, and that's stuff we're aware of, and we have some robustness, and also in the main specification we have hour of shift fixed effects to help deal with this. Yeah, yeah.
And it's saying that diagnostic orders have, are not, the cost doesn't depend on hours, so it's increasing less in hour than the thinking. But it's easy, it's harder to like think about something than to go like ask the RA to run something. You have to look at what the RA did back eventually, similarly like ordering diagnostic tests, you have to like look at, so the simplest thing if you're tired is to be like, you have X go home. But I mean, my question is like, would all your results go through if order diagnostic orders at a cost that is increasing in L is not as fast as thinking?
We haven't solved that, but I think the answer is yes. Yeah. Yeah, Ashley.
So, like, if I'm really tired, then it seems like throwing spaghetti at the wall and seeing what sticks would be a good idea. And the really valuable orders would be ones that tell me exactly what to do. They might be costly to run these tests, but they give me really clear guidance. How does common versus rare map into like the value of the test?
Yeah, it relates to we're doing this in a rational and attention framework, but you can think of it as like kind of a Bayesian regularization thing where basically like think of it as just you've done less thinking up front with the timing of the model. So you just know less about this patient. So if you try to do something that's really targeted, you're just not going to have kind of the information to target that really well. That's the idea. Now, I want to be clear. In the paper, in the model section, we have a couple pages where we talk about how does this relate to alternative models, right? And there's different versions of this. This does not have to be the only version for sure. But that's how we're thinking about it. Yeah. And that's going to be borne out empirically, obviously. Let me do one more question and then keep moving. Yeah.
Probably you'll talk about in the data part, that what led to more patients getting sort of crammed into a 90-minute window as opposed to another 90-minute window in which there are fewer patients? Because if these patients are somehow acute and they call into their doctor and this is like the same day appointment, they're probably just experiencing something that would fall in the sort of total diagnostic orders and common diagnostic orders kind of thing.
Totally. Yeah. This is the emergency department. So there aren't appointments. And we're using also, of course, like day of week and time of day fixed effects too. Yeah. You'll see. I'm going to talk about it right now. So setting in data, it's patients who arrive at the ED at UCSF from 2017 to 2019. We're going to follow people until they're discharged. So for admitted patients, we have data until you leave inpatient, even though we're not leveraging that so much right now, apart from some simple things. A lot of patient data, insurance status, age, gender. Chief complaint is very important. At the most granular level, that can be one of 300-ish different things that we're going to use in that prediction model I was talking about. For providers, we observe their role since, of course, UCSF is a teaching hospital, gender, department, etc. So I'm going to be very brief with this since this is a health audience, but this kind of maps how we're modeling the ED process. So the patient registers, and then that's with kind of the person at the desk up front. They say what's their chief complaint, what are their demographics for the patient. Then the patient's assigned to a provider in what we call a quasi-random way. I know other papers have studied this. I'll talk about this a little bit. Then patients go into this loop where the provider does clinical reasoning. They order diagnostic tests. They get results from those tests, and then they continue with this loop until they make an admission decision. And the admission decision is then, do we admit the patient to inpatient or do we send them home? And that's how we're thinking about this at a high level. Okay, clinical data is the universe of orders made. What's the order? What's the procedure or medication? Is the result abnormal? Timestamp to the second. These are associated with both the provider and the patient. And we're not using this in the current results I'm going to show you, but we observe also when the providers view the results and access the results as well. That's coming from the audit log data, which is on top of EHR data. It's sourced from it, but it's essentially clickstream data that looks at when are physicians kind of clicking on different results or viewing different screens and things like that. We observe information on notes. That's in the appendix now. I'm not going to talk about it too much. Okay, some demographics. I'll just hit the highlights in these summary tables. They're also in the paper. We have 76,000 patients over the 2-year period, so I want you to think about that as our sample size. A whole range of ages. Another key statistic here is that the share of patients upgraded to inpatient, so admitted to inpatient from the emergency department, is 24%. Okay, so that's an outcome we're going to be looking at. And if they are admitted to inpatient, the typical length of stay is 6 days. And the average length of stay in the emergency department is about 7 hours. We're not really focusing on that here, kind of what the insurance is. And through our discussions with them, it's not something they're considering in the emergency department. Unless the person's telling them verbally, I think, yeah. Okay, so this is some severity descriptives. Here, immediate through non-urgent is basically the acuity severity score that patients get at intake, 1 through 5. Most people are rated 3. 20% of people are rated 2, which is more severe or emergent. And then about 15% are 4, which is less urgent. Then you can see the statistics for abnormal vital signs. The reason to show you this is just this is going to be important information we use in our predictive modeling. The typical number of diagnostic orders per patient is 4.5, and the typical number of consults per patient is 1/4. This gives you a sense of when I talk about chief complaints, what we're talking about. This is not all of them. This is just kind of the top 10. Abdominal pain and chest pain are the most common too. We're also going to rerun our analyses specifically for these two, and if I have time, I'll talk about that. Okay. For the doctors, a lot of them are residents. About 20% of them are attending. We observe the phase of the residents. Typical number of shifts in the data for a provider is 32. And average shift length is about 12 hours. Yeah, question. Yeah, the way we're going to do that here is we have an algorithm that, basically, so first of all, the patient is assigned to a specific provider, and then we're only going to be using patients where the provider, or we're going to be assigning patients to that specific provider, also double checking that with the intensity of the treatments. So kind of who's giving the treatments and who's writing the notes. We don't have a model of teams here with that in mind, but I do think that that's an interesting extension for this work. Tim, yeah.
Rather than send out a test when you're overburdened to this delegate solution in some way. And how do you think about that? I mean, I assume you saw some of that, but maybe not all of it, because if it is like attending a resident that show up to talk to somebody, and the attending, if he's just overburdened, just says, you take it. I don't know how that shows up. Like, how does that?
Yeah, we observe what we observe, which is kind of what we showed you. I mean, and then as I just mentioned, we use the algorithm based on those observables to kind of validate the assignment. You could imagine that actually this is a use for the clickstream data too, that we haven't used yet, where you could say, well, that's one thing. Who's actually clicking on like the order and the results? Who's clicking on them and reading them, etc. Yeah.
Maybe separately that, like, having crowded, that the more experienced docs, like, get the harder cases, right? That it kind of, everything kind of cascades such that the easier cases are going to the.
Oh yeah, that's stuff we check with balance tests. That's not really an issue. Yeah, Janet.
People being missing from a shift, like maybe I get a lot of patients because somebody who is supposed to be there
Yep.
didn't show up. Are you gonna use that kind of variation?
Certainly just implicitly in the background, the variation is it's in part due to that, right? Because if someone misses a shift, that's going to be a shock in the way we're doing this. We could do that. We actually have data on shifts and when people are supposed to work. So we could actually even go further and look at those specific cases, but I think it's kind of implicitly in the measure already. I'm gonna keep going just because I want to get through the main results. So let me talk about the measure of cognitive load. It's the way we're developing the measure is the number of complex tasks or decisions a physician has to make at a point in time t. We're going to assume this is an assumption we talk about in the paper. We like it in general, but it's not perfect. We're going to assume that patients requiring more notes, more consults, and more tests are more cognitively challenging for a physician to diagnose and treat. And we're going to develop that with a predictive model. So it's not going to be ex post, which I'm going to talk about in a second. The timing assumption in the main results I'm going to show you today is a 90-minute window relative to the index action that the provider is taking with an index patient. In the appendix, which is really long, there's lots of different iterations of this showing similar results. We're going to deal with two problems that I'll touch on here. One of them I mentioned is that the number of orders, tests, and notes, of course, for a given encounter is endogenous. The way to think about this is if you're a physician and you've had a tough day, we don't want to use the actual orders, tests, and notes that you actually gave to this patient because that's what we're trying to measure the effect of, okay? And so for this, we're just going to basically measure patient intensity using the ex-ante measures from before the patient is assigned to the physician. That's on the next slide. And then the second thing is we need random variation within doctor. That refers in part to what Janet was talking about, but which of course can also just come from stochastic arrival of patients given a staffing level. Okay, so the ex-ante measure, I'm not going to belabor this, but I will talk about it for a second. It's a predictive measure that's based on the characteristics a patient arrives with. To do this, we're going to run 3 lasso models that predict 3 things: the number of orders, the note edit time for a patient, and the consult, so the amount of time you're asking other physicians, specialists for help. The variables we're going to use in the predictor are chief complaint, comorbidity index, acuity codes, and abnormal vital signs. So this is all the intake information. So before the encounter or before you start engaging with a physician, what we're going to do is we're going to use these variables to predict these 3 outcomes. And then for these 3 outcomes, we're going to synthesize them into a one-dimensional score using a z-score method. And then we're going to use that to sum up and create a measure for a given patient, which is the measure C in the summation below. So the way to think about this is that each patient is given an intensity measure from this predictor, which is C. Then imagine I'm taking an action for an index patient. So imagine I've seen 10 other I'm seeing 10 other patients in the last 90 minutes. And I want to know something about what's the impact of that on seeing a specific patient right now. The measure of that cognitive burden from seeing other patients that's going into the regression is this F measure. And the way to think about this is that within the relevant time window, the F measure is summing up the intensity measure for all the other patients I've seen, not the index patient. Okay? this gives another, this kind of chart gives you a little bit of an example with the timing, okay? And so if we kind of think of an event taking place for an index patient at time t and a physician that's seeing 4 patients, patients A, B, C, and D. Within the most recent 90-minute window, if the index patient in the regression is D, the complexity or predicted intensity of patients B and C here will count in the prior 90-minute window. In the window 2 lags ago, patient A and B are going to count in that measure. Patient D is not going to count as the index patient. Okay. In the interest of time, I think I have about 15 minutes left. I'm going to ask for your faith here about conditional random assignment in the ED. I know that people have worked on this before. We do a lot of tests. We do a lot of balance checks. It looks good. All right. I know this is, not a trivial thing, but in the interest of time, I'm going to move on. The things I do want to show before I get to the regressions based on this are how we're thinking about the variation and what this variation looks like, just to give you a little more confidence in these measures. What this chart is plotting is the average cognitive load trajectory for the 20 residents with the most cases in the data. So what this chart is showing is hour of the shift is the x-axis from 0 to 12. The cognitive load measure I've developed that I just told you about on the y-axis. And what this is showing is the lines for 20 different residents across, and what each line is saying is for that resident, what's their average of this cognitive load measure at this hour of the shift across all their shifts. Okay, so I want you to think about this as like an average measure. And so you want these lines to be really close together, right? If you believe in conditional random assignment, that's the way to think of this. This then gives you a sense of what this looks like for one resident if we look across their shifts. Okay. And what the key thing, and this is, of course, we're looking at this statistically and doing a variance decomposition as well. The key thing is that these lines are much closer together than these lines, okay? And what that's telling us is that there's a lot of variation at the individual level relative to the cross-sectional level across physicians. Okay. And statistically, when we look at this in the paper, almost all this variation is coming within individual rather than across individual. Okay, let me talk about the regressions. We're going to implement a series of models with this form. Y is an outcome variable. F is a function of the cognitive load variable that I was telling you about for this physician and patient at time t. The thing in the parentheses in the middle is an aggregate of prior cognitive load before the most recent 90-minute window. So there's an aggregate and then there's the recent window. We also have versions where it's kind of a sequence of lags, which I'll try to talk about. The key thing here is that there's a lot of fixed effects here. In addition to the X variables, there's physician fixed effects and there's time fixed effects, so day of week, hour of shift, time of day, etc. The goal, what we're trying to identify in this regression is the beta term, which is the effect of the cognitive load variable on the outcome variable. And in some cases, we're looking at the gamma variable as well. The focus on the outcomes of interest, which I'm now going to show you, is on outcomes related to the diagnostic process. Okay. So first outcome we're going to look at, and these outcomes are going to follow the model predictions I talked about earlier. The first is going to be the number of diagnostic orders, so the total number of orders you're placing. And here, when you have one standard deviation higher cognitive load for the same physician, same patient, kind of conditional on X's, etc., you place 5% more diagnostic orders if your cognitive load is one standard deviation higher. Here, we then, instead of doing a linear specification in standard deviations of cognitive load, we do it with quintiles. So what this is doing is it's saying, for the same physician, Cognitive load quintile 5 means this is like my worst day. 1, which is the reference point, is it's my best day or best day / time period. And you can see that it's somewhat convex. And here, if you look at yourself in the 5th quintile compared to yourself in the 1st quintile, you're doing about 10% more diagnostic orders. Okay. Now we're going to talk about common orders and rare orders. Okay. Common, if you think of just top 25 diagnostic orders, rare is non-top 25 diagnostic orders, more targeted. Here, if in the linear version with standard deviations of cognitive load, you're increasing the common orders you place by 7% with a 1 standard deviation increase in cognitive load. You're decreasing the number of rare orders you place by 5%. Okay. This shows the quintile version of that. Here, what you can see is the same convexity for common orders. You're increasing by almost 20%, going from your most cognitively loaded state to your least, or sorry, the reverse, going from your least to your most. This is the same for the rarer orders. And here, if you're in your most cognitively loaded state, you're placing about 20% fewer rare orders than when you're not. For the same kind of patient, conditional on X's, and the same provider, obviously. Okay. Then what we do is we develop this statistical measure of diagnostic entropy from information theory. I'm not going to have the time to kind of describe the math behind this measure. Yeah, go ahead, Arlen.
Say like they take lower time to analyze, they're quicker to show up and could be actual human system that have less time.
Yeah, I'll talk about that a little bit later if I have a chance. The broad answer, or the simple answer is they're broader orders. Yeah, sorry. The simple answer is they're kind of broader, less targeted orders. In fact, this entropy reduction measure we develop, it's like a statistical measure of kind of like how targeted or coarse are these orders in terms of the final diagnoses they're predicting. I don't have a lot of time to talk about this measure, but basically what this measure does is it says, take the orders you're placing in the first order batch you're placing for patients after you've met them, after you've done some thinking about what's wrong with them. It asks for those orders, look in a full cross-section, how predictive of these orders, how predictive are these orders of specific final diagnoses versus just a broad set of final diagnoses. And so take a specific final diagnosis. Is this order highly predictive of that final diagnosis, yes or no, or not? Right? That's kind of what this entropy measure is statistically developing using the data. And so here, from a result standpoint, what we find is when you have 1 standard deviation higher cognitive load, the entropy reduction you have in the first order batch is about 3% lower. So essentially, statistically, the orders you're placing are coarser and kind of targeted towards a much broader set of diagnoses rather than targeted towards like more narrow diagnoses. So I guess you led me into this. Yeah, Tim.
Oh, patients are identical. I guess one thing that probably differs with high cognitive load times is that they waited longer because there's more people in the ER. And I guess is there any sense in which waiting longer might actually change what I'm demanding, might actually change the optimal treatment, given that some of these are acute conditions and like I need to do something faster if they've been waiting for 3 hours than if they've been waiting for 30 minutes? Like, how should I think about that difference?
Yeah. There's a lot to talk about there. Let's talk about it more after. The one thing I'll mention is we have a version now with the model where we do it with what we call congestion controls for the entire ED. And that's basically putting in like a measure of ED congestion into the individual level regression, which helps. We're going to have another result also, which shows what you were saying in terms of like the process measures versus the diagnosis measures. Okay. So the next thing I want to talk about, a really key outcome, is the inpatient admission and readmission, which we kind of talked about in the model. What we find is that for a 1 standard deviation increase in the cognitive load measure, same physician, same kind of patient is 10% more likely to admit the patient to inpatient. Okay. Then if you look at this in deciles of cognitive load, so 10 is my worst day, 1 is my best day. When you're in your 10th decile, you're about 28% more likely to admit a patient to inpatient for the same kind of patient than when you're in your worst decile. Okay, then I think we ask the natural follow-up question here, which is, well, okay, who are these marginal patients who are being admitted, the 30% who are being admitted? And so we run a Abity 2003 style complier analysis to look at who are these marginal patients. And essentially what we find is that they're less severe which is not surprising, I think, from an ex-ante point of view. Their acuity level is on average lower. They're less likely to die in inpatient. They're less likely to be readmitted within 30 days. One interesting thing, though, is that their length of stay is still on average reasonably long. So if you're a marginal admit because of the cognitive load measure, you're still likely on average to stay in inpatient for 4 days. So it's not like you go in and you go out. So it's costly. Yeah. Right.
If we believe that decision making is better at low cognitive load, which you haven't actually argued, right? Wouldn't that imply that conditional random assignment is a giant mistake by the hospital?
We talk about that actually towards the end. I'm probably not. I might have to tell you about it later, but it's in the paper. Yeah, and we're not saying anything about optimality here, to be clear, because like. Of course, it could be like in a Roy model style sense. If you're more cognitively loaded, if there's staffing constraints, we might not want you to do the same thing, right? Just to be clear. Though you couldn't implement tools and things like that. Okay, so what this table shows is it takes us back to the model predictions and then it shows the analog empirical results, essentially showing the quantitative magnitude and then the implications. Additional analyses in the paper to tease are all of these additional analyses. The one thing I want to talk about before I wrap up here of these additional analyses, the second one is Brad's, which I'm not going to get to. The first one is cognitive load versus alternative mechanisms. Okay. We think cognitive load is a natural description given the way we're developing the measure. However, there's possible alternative hypotheses where you could write down a model and it delivers pretty similar predictions. One of those we call provider level time pressure and redirected optimization. So it could just be you're really busy, you're not cognitively loaded, you don't feel like super tired, but you just start doing different things because you get so busy. The second thing is ED-wide time and resource congestion, which someone brought up earlier. So we have 3 analyses we've done in the paper to kind of support cognitive load as a mechanism. One is we use the lag paths of the cognitive load measure to perform tests for the time and busyness hypothesis versus a cognitive load hypothesis. Just in the interest of time, the way to think about this is that if you had a really hard time earlier in your shift, but all your patients are gone, and your last 90 minutes was really free, that's a nice test of cognitive load versus the time and busyness thing because you're not busy anymore, but you had a lot of cognitive burden earlier in your shift, okay? And with this analysis, we basically find that it's supporting of cognitive load as at least a meaningful mechanism underlying what we're doing. Yeah, Marcella.
Might not tool that making these decisions risk important spillovers, and there's this adage in medicine, never worry alone. So I wonder if the attending's busyness, like if there's a really big case that is taking away the attention of the attending, kind of similar to the function of adding additional labs. Like you might see more labs and go and talk to your attending, most of their pamphlets.
Yeah, that's something we could look at. We haven't done that. Yeah. Okay, Kit's giving me the 1 minute, so I'm gonna hurry. I'm gonna tell you what these other two analyses are and refer you to the paper that will be posted in 1 week, since these are new analyses. The other thing we look at is impact of a recent patient death. This is outside the main regression framework, while the first one was inside. This basically says if you had a patient that died, what are the impacts over a 14-day or 1 week or 14-day period? And what we find is actually predictions in line with our model of cognitive load, even going 14 days out, looking out over a 14-day period. So that's kind of a test of this because ostensibly that should be uncorrelated with busyness, time constraints otherwise. The third thing we do, which is what Tim was asking about, is we look at the ED-wide congestion impacts. And here what we find is that if anything, the impacts on the diagnostic outcomes go against our model prediction, so it works in our favor. But of course, there's big impacts, as you can see in the bottom, on minutes to pick up and ED length of stay when the ED is congested. Okay, I'm not going to talk about counterfactual patient assignment. I'm just going to wrap up. Just to kind of take us back to the beginning, I think there's very limited work that's studying cognitive load in settings with experts, especially settings with high scale administrative data. We think the data set here is a really nice data set for studying this. And I think that many of you have or will have access to data sets like this. And there's a lot more to do in this space. And of course, in the healthcare space, most studies of productivity variations typically focus on the cross-sectional level, though, of course, there's some notable ones at the within provider level. Next steps. In the paper, we have a causal forest model of physician heterogeneity of cognitive load effects that shows we're essentially underpowered with this sample to detect real heterogeneous cognitive load effects. I think with a sample 5x, 10x as big, that could be really interesting to do. I think that lab in the field studies, studies with decision aids, of course, could be very interesting. Per the question, I think Brad brought up, I think there's really interesting scope for questions here. That's basically like, if we want to give you advice on what to do when you're cognitively loaded, or if you just have lower productivity than another physician, do we want to match you to the best version of yourself? Do we want to match you to the best version of some other physician? There's a lot of interesting kind of Roy model questions within person and across people that I think are really interesting. And then as discussed here, I think thinking about shift design and the labor staffing implications here is important as you move to the next level of what are the implications? What do you want to do about this? Yeah, that's it. But I'm happy to talk more at any time during the conference, and thank you.
Thank you, Ben. So we'll now break until 20 minutes after the hour. If you have not uploaded your egg timer, please come and do that. in any of these egg timers. We're very happy to have Kaveh. Dinesh.
Hi, everyone. I will be talking about some joint work with Arlen Guarin and Christian Pozo on the early career effects of anxiety and depression. As motivation, what I'm showing here is an age-wage profile from our EE data in Colombia. Consistent with some seminal work in labor economics in the early 90s, you can see that wage growth is most rapid in the early career. Now, if we superimpose visits for anxiety and depression, now using our national healthcare claims data from Colombia, what you see is that these conditions tend to arrive precisely around that time that wage growth is steepest, which gives rise to the question of whether workers affected by anxiety and depression might fall behind their coworkers or their peers on the job ladder. In this paper, we first ask what are the long-run effects of anxiety and depression on labor market outcomes, and we look into this question using a differences and differences approach around new diagnoses of anxiety and depression. Then in the second half of the paper, we ask whether timely mental health treatment improves earnings using an IV strategy. To very briefly preview our results, monthly earnings declined by 7.4% 2 years after diagnosis, and specialist mental health treatment increases monthly earnings by about 10% 2 years after diagnosis, implying that treatment closes the gap among compliers. We use two data sources called PILA and RIPS. PILA is monthly employer-employee records for the universe of formally employed workers. The key limitation here is that we don't observe earnings for people in the informal labor market, which is about 50% of workers and 20% of economic activity in Colombia. Second data set is RIPS, which is national claims data covering all encounters, including mental health counters in Colombia. Key limitation here is that we don't observe diagnoses, or we don't observe people with undiagnosed anxiety or depression. We link these two data sets at the individual level and then construct a monthly worker level panel spanning from 2009 to 2018. A bit about how we construct our sample to identify newly diagnosed workers. We require a baseline level of attachment to formality. We then scan for workers who are diagnosed with anxiety or depression between the ages of 18 and 45. Following some work by Carlos Dobkin and colleagues, we require that people have no mental health diagnosis in the preceding 3 years, and we also drop people with any history of pregnancy or parental leave in the 3 years preceding diagnosis. That gives us about 51,000 workers with new diagnoses of anxiety or depression. We then construct a matched comparison group to help trace out their counterfactual labor market trajectories. And we do that using following a paper by Andrea Weber and colleagues where we match to coworkers. So specifically, we look for each of those 51,000 workers, we find people who are in the same firm, industry, and city at baseline. And then using that set, we propensity score match 1-to-1 each worker to somebody within that comparison set. I'll be very brief about some sample characteristics. I'll point out the sample sizes at the bottom. As I said, about 51,000 diagnosed workers, about 51,000 matched coworkers. The average age in our sample is 31. And then diagnosed workers, about 58% female, and earn about $8,800 per year, which puts them about the 70th percentile of the income distribution. So you can think of these as relatively well-off folks at baseline. Here's our first result. The x-axis is months since diagnosis, and the y-axis, as convention in event study, is change in earnings relative to period -1, month -1, 1 month before diagnosis. What you can see is that earnings are relatively flat leading up to the diagnosis, and then there's a relatively sharp onset effect such that 2 years after the diagnosis, earnings are 7.4% lower than they were a month before diagnosis. I should say that these estimates were obtained using Callaway-Santana. When we then decompose change in earnings into changes in employment, days worked, and daily wage, we see that the sources of earnings loss changes over time. In the very early months 0 to 2, the intensive margin actually makes up about 40% of our effect. And when we further decompose this, we see that it's largely driven by people taking non-labor sick leave as opposed to other sources of total days not worked. The extensive margin matters most in the long run, making up about 80% of our effect at 2 years. We can further decompose this into EN and NE transitions where N is non-formal employment. And what we see here is that after onset of these diagnoses, probability of flowing into formal employment goes up. The probability of flowing out of formal employment goes up. The probability of flowing into formal employment goes down a bit less. And then there's some evidence of long-run labor market churn. Wages account for about 13% of our effect at 2 years. This could be due to people staying at the same firms and not growing their wages within that firm, or transitioning to lower paying firms. To distinguish between these two, we use an AKM, and then we put estimate the AKM in the largest connected set of firms, which is slightly different than our analysis sample, but the samples, our event study results in that subsample hold up. We get a dummy for being employed at a firm in the top quartile of firm effects. And when we put that on the left-hand side of our event study regression, we see that there's about a 7% drop in the probability of remaining employed at a top quartile firm. I'll say a bit about robustness. Number 2 here, you might worry that people are transitioning to informal employment, thus leading us to overstate our effects. Sectoral attachment in Colombia is fairly persistent. About 95% of people who are employed formally in year T remain formally employed in year T+1. And then as further reassurance against this possibility, we stratify workers based on their pre-diagnosis attachment to formality and find that our effects are actually larger for people who are more attached to the formal labor market at baseline. I'll also touch on reverse causality since this often comes up in this literature. So we think our flat pre-trends help protect against this. We think that the fact that we match to people who are coworkers who likely fit similar labor shocks also helps protect.
And we're very happy to have Emily Cuddy.
Perfect. Thank you so much to the organizers for putting our paper on today's program. My name is Emily Cuddy, and I will also be talking about the labor market consequences of poor mental health. This is joint work with Rania Helensdotter and Elisa Hakame. That I'm just. Oh, I see. Good. Okay, depression and anxiety are among the leading causes of disability worldwide, and they have a combined economic cost of over $1 trillion annually. But perhaps surprisingly, despite these figures, there's relatively little credible causal evidence on the labor market consequences of poor mental health. And that's the gap that we're aiming to fill with this paper. We're going to provide causal estimates of the effect of depression, anxiety, and self-harm on labor market outcomes. To do this, we're going to use full population Swedish admin data, which is going to link health records to information on earnings, employment, and social insurance. We'll be focusing on acute, severe episodes, those involving a hospitalization, and we'll leverage variation in the timing of those hospitalizations for identification in a stacked difference in differences design. Our headline result, we're going to show you that these crises are going to generate immediate and lasting damage to labor market outcomes, yielding both labor force exit and scarring among those who manage to keep working. Now, a quick word on why we're focused on hospitalization. A first psychiatric admission marks a moment when a mental health crisis is undoubtedly severe, and it also provides us with a clean date on which to anchor time. Now, you can compare this to something like a first diagnosis or a first prescription. Those are more complicated because they require someone to go and seek care, and they require a clinician to decide to diagnose or to prescribe. And so the timing may be more endogenous and the severity may be more ambiguous. A mental health crisis, on the other hand, is much less a matter of choice. And in fact, about 93% of ours are fully unplanned. They're also not an institutional treatment. Okay, so the stays that we're observing in our data are often quite short, on median about 3 nights or less. What we're estimating in this paper is the total cost of the crisis itself. Okay, and I want to note that it is not a clinical outlier. Our calculations suggest that about 10 to 20% of those individuals in Sweden who are going to receive a diagnosis for one of these 3 conditions will end up being hospitalized before they reach middle age. All right, a bit more on the data. I told you we're using full population Swedish admin data that's linked at the individual level. It'll contain health, labor market, and public assistance outcomes. Importantly, it's going to contain total income from all sources, which is important because then we can assess people's economic well-being over time. For our sample, we're going to keep only those individuals who have been hospitalized for depression, anxiety, or self-harm at age 25 or older. We keep only the hospitalized because they're at very different levels and trajectories than the general population, and so they may be a less suitable counterfactual for them. Instead, we keep only the hospitalized, we compare them to one another, and we leverage variation in the timing of those hospitalizations for identification purposes. Now, before I show you any regressions, I want to show you 2 pictures that'll give you the intuition behind our design. This is the employment rate for 4 groups in our sample, people hospitalized at age 26, 28, 30, and 32. What you can see is that all 4 groups are on a common trajectory prior to their hospitalization. And then when they're hospitalized, you can see here that their earnings decline. Okay? That common trajectory is our identifying assumption. Those that are treated later in time simply haven't reached their crisis yet, and so they serve as a valid counterfactual for those who haven't been hospitalized, what they would have looked like had they not been. All right. We're going to formalize this in a stacked difference in differences design. Okay, we're going to compare individuals hospitalized in year Y to hospitalized in year Y plus 5. We'll estimate event study regressions, and we'll estimate effects relative to 2 years prior to the hospitalization. We'll do this because it'll allow us to observe part of that pre-crisis deterioration in year T minus 1. Okay. Again, what's the identifying assumption here? It's exactly what I showed you in those pictures. Treated in control, absent their crisis, would have continued to move in parallel. Okay, now what's baked into this identifying assumption that there aren't other shocks that are happening right around the time of the hospitalization itself. Okay, and I'll show you in a few slides the different things that we've done to assess this possibility. Now, you can see in this picture, the effect of these crises is very large, okay? We're plotting the employment rate. You can see that it takes a hit in the year of hospitalization, it bottoms out the next year and remains persistently depressed, okay? This represents about an 11 percentage point drop in employment or about a 14% decline. When we look at earnings, we see a 22% decline, okay? And this represents about a cumulative 4-year loss of around $23,000. In the paper, we're going to do an accounting decomposition to figure out where these earnings losses are coming from. And we find that about half are coming from people who fully leave the labor market, and the other are coming from those who stay. Okay, so in other words, those who keep working face a persistent wage penalty. Now, getting back to that identifying assumption, I told you what would be a threat to us is another shock that happens around the time of the hospitalization. A really obvious candidate for this is something like job loss, okay? We don't see signs of an Ashenfelter dip in separations, and we observe that UI receipt is very flat in event time, okay? You might also worry about other types of life circumstances that are changing around hospitalization, things like a divorce or bereavement. We look in our data and we show that those types of shocks are relatively rare. They're equally likely in our treated and control groups, and we find that our results don't change when we identify the individuals that have those shocks and remove them from our sample. Okay. Now, how big are these effects? We're going to benchmark in 2 different ways. First, running the exact same design with the same data, but for physical health shocks. Okay. What we'll find is that our employment effects are 3 to 4 times the size of those from heart attacks or serious transportation accidents. We'll also benchmark to other shocks that have been studied in the literature, things like job loss or incarceration. Again, we'll find that our effects are much bigger. So what this is telling us is that these mental health crises are having among the biggest effects that have been studied in this very large adverse event literature. Okay? They're also remarkably persistent. In a complementary match difference in difference design, where we're able to follow people for a full decade after their hospitalization, we see, if anything, slightly larger effects, but we also see no sign of recovery. Now, this is Sweden, after all. They have a very generous safety net. Does it catch these individuals? The answer is partially, at least in the short run. Okay, you can see here that their temporary sickness program kicks in and replaces about 2/3 of those earnings losses that I showed you. But when we look at total income, including transfers from all sources, you can see that it still declines by about 8% and remains depressed. This is representing about an annual loss of about 3 months of living expenses, okay? So as a result of these crises, people are persistently worse off. Now, I've told you that these effects are large, they're persistent. What is driving them, okay? In the last part of the paper, and in today's talk, I'll go through a couple of the channels that we've considered. The first is about benefit generosity. This is Sweden. They have a very generous social safety net. Are people simply coasting on benefits? To examine this possibility, we're going to exploit a 2008 policy whereby Sweden implemented mandatory work capacity assessments. Okay? We'll find that this new policy did increase bunching of exits around these checkpoints, but it doesn't appear to soften the blow that these crises have to people's labor market settings. It seems like the severity of the illness does matter. Okay, so we're going to find much larger effects for people who stay in the hospital for longer, proxying more severe crises. We'll also see signs of occupational downgrading. So workers are moving towards jobs that are less cognitively demanding and more irregular. Okay, so some of this is a true durable loss of work capacity. It also seems to matter quite a bit the type of employer you are and where you're working. Okay, we'll see larger effects for low wage workers, low tenure workers, and workers at small firms. Now, there's sort of 2 stories that fit these data, and we're not able to fully separate them. The first is about the employer itself. Okay, so a large employer has slack. They can hold your job open for you as you attempt to recover. A small firm probably has much less capacity to accommodate. It's also potentially about the worker. A high wage, high tenure worker probably really likes their job and they're less inclined to leave it. They also have more firm-specific human capital. And so you might think that their employer is going to fight really hard to retain them. Okay. More speculative cut is that we see smaller effects for weekend admissions. This may say something about employer observability, less observable, less stigma, but it also could reflect some selection in who gets hospitalized over the weekend. Now, to conclude, I want to leave you kind of with two thoughts. The first is that we're studying severe episodes in this paper. And so to the extent that you think we're delivering you the full economic costs of depression, anxiety, and self-harm, we're likely delivering underestimates, okay? And second, because these effects are so large and they're happening so early on in people's working trajectories, you can very easily say that they're likely to have larger lifetime costs than many of the physical health shocks that have been studied so far in the literature. And so we feel like they're very much deserving of our continued attention. Thank you so much.
Thank you so much, Emma. And as we load Chris's slides, let me just remind you that if you would like to engage further with Emily during the long break, Emily will be placed inside deep in the bull ring here. And switching away from mental health, we're very happy to have Chris Whaley.
Thank you for having me, and really excited to present our paper on what happens when insurance companies delve into physician spaces. This is joint with both Jeff Marr and Xiaoxi Zhao, both at Brown. One of the, I think, largest structural changes in the delivery and organization of healthcare markets over the last decade or so has been the emergence of platformization of firms. And so if you look across the nation's largest insurance companies on the left, they have really delved into and integrated with a variety of providers and kind of more medical specialties, largely with the exception of hospitals. They've integrated with specialty care, a variety of health and wellness, primary care services, home health care, virtual care, and a variety of other pharmacy-related services. And so this has really, I think, reshaped how care is both financed and delivered in the United States with lots of uncertain implications. And so in this study, what we're going to focus on is really the nexus of the nation's largest insurer, UnitedHealth, and their integration with primary care services through their largest subsidiary, Optum. And this is a growing area of integration. It's a potential concern that's raised lots of regulatory and other scrutiny. On the concern side, this could be something, or at least on the benefits, reduces double marginalization, kind of the classic integration story, especially in healthcare and when we're financing through capitated payments, largely through the Medicare Advantage program. This could be something that aligns the incentives of the insurer and the provider to provide care efficiently. And it could also be something that increases investments in information technology, aligns utilization management incentives, and actually improves the delivery of care. On the other hand, this could be anti-competitive if it is essentially a vehicle to capture patients from a rival insurer, whether particularly in the Medicare program, that's traditional Medicare, or another Medicare Advantage program, which could lead to restrictions in access, constrained patient choices. And then a key focus of our paper is how this can actually align incentives to increase coding and how that can increase payment, particularly within the Medicare Advantage program. And so we're going to look at three questions. So does the integration between physicians and an insurer lead to some evidence of rival foreclosure? And by that, we mean, when United acquires a physician, is there changes in the share of patients that physician treats that are either from another Medicare Advantage plan or from traditional Medicare? We're also going to look at whether we see changes in risk score intensity. And this is the vehicle that CMS uses to pay providers and insurers for taking on Medicare Advantage plans and to stabilize MA markets. And then we're also going to look at some evidence of care quality. The, I think, hardest part of this paper is identifying these acquisitions. These are arrangements that, at least in my opinion, are intentionally opaque. And there's actually not a good set of data on when an insurer acquires a physician practice. And so we're going to use a three-step approach. We're first going to use data from Medicare on practice environments. We initially, when we started this program, thought this would solve our everything. But when we got into the data, we found only a few thousand physicians listed in the Medicare data who were affiliated with United. So we're also going to look at SEC 10K filings and also some state regulatory filing data. And so just to highlight the latter two, in the United Health 10Ks, they're required, like other public firms, to list significant subsidiaries. And so we're essentially going to extract over several years the full set of subsidiaries from their annual 10Ks. Just one note, the list of subsidiaries in United has grown from 344 to over 2,000 over about a decade. And we're essentially going to pull the names of physician or of practices, rather, firms that are listed as subsidiaries, and then link that to data on practice organization and try to identify physicians who are working for that practice. Then we're also going to use data from the state of Tennessee, which requires firms that offer Medicaid managed care to report their full set of subsidiaries and essentially their family tree. And we have this data for several years. This data is a bit of a bear to work with, but the advantage is that we essentially get the family tree, if you will, for United. And so there are, within this data set, or in these filings, literally hundreds of pages of PDFs of this type of data. The advantage is within each of one of these cells, and so this shows the subsidiaries for Optum, we get both the name of the subsidiary as well as the tax ID. And so we're going to use image recognition software and essentially extract the names and importantly the tax IDs, and then look at physicians who are billing under that tax ID and essentially monitor and measure when a new tax ID comes in the system. And then we're going to link this to Medicare Advantage and fee-for-service data and focus specifically on primary care physicians. And so we're going to attribute a Medicare fee-for-service or MA patient to their common primary care provider and essentially measure whether or not, or what happens to that patient once that primary care provider's practice is acquired by Optum. We're going to use a pretty standard stack different event study approach. And again, just measure before and after relative to unacquired physicians, what happens to the patient and to outcomes. And in the paper, we've got a bunch of different robustness tests, alternative specifications, matching, et cetera. Those largely don't change the results. And so what do we find? So when we use this data, we find about 200 acquisitions of physician practices from United over the 2017 to 22 period. And so these are going to be our treatment set of practices. And importantly, these impact about 100,000 Medicare beneficiaries, whether they're in MA or fee-for-service. And so the practices that United acquires tend to be relatively large. When we look at what happens to foreclosure, we find pretty limited evidence. And so if you look at on the top panel, what happens to the share of a physician's patients that are from traditional Medicare or specifically from United Healthcare in the second panel, or in panel C, what happens to other MA plans, we really find pretty modest effect. And so if you're going to interpret this, at the highest level, we find about a 1 percentage point decline in the share of patients that are from another MA plan, but that doesn't happen until several years out. If we stratify that based on where United as an insurer has lots of market power, has variations in market power, we do find some evidence that in counties where United is a lower penetration on the MA side, that there is some evidence of uptick in foreclosure. And if we look at changes in patient composition, whether we look at patient age, their share of female, race through the share that are white, and some measure of income based on dual eligible status, we find no evidence that there's changes in patient composition. And if we look at quality, looking at ED visits, we find no change in ED visits over time. Another measure of quality is the share of patients who go to an emergency room. We find a pretty modest increase, and again, not until several years out. And so I certainly want to interpret this as quality is drastically changing. Where we do find pretty meaningful and important effects is what happens on the risk score coding side. And so here we measure what happens to a patient's attributed patient's HCC, which is the risk score model that CMS uses as a base of payment on the MA side. And we find that in both traditional Medicare and more importantly, in Medicare Advantage, there is an increase in risk scores, especially on the MA side. The risk score measure increases over time pretty steadily and reaches about a 20% increase in HCC scores, corresponding to about a 20% increase in payment several years out. And importantly, this is not something that is limited to just United. If we look at both United and other patients that are insured by other MA insurers that the physician treats, we actually find pretty similar increases in risk scores for those patients. And so just doing a bit of back of the envelope on what the change in risk scores means, we find that for traditional Medicare patients, there's an average about a 4% increase in risk scores. Among United patients, about an 8%, and about a 7% increase among other MA or patients insured by other MA plans treated by the same doctor. And so we just kind of add that up. We find that as a result of higher risk score payments, United captures about $100 million in extra payments from CMS, but other insurers are actually capturing even more, about $167 million. And so out of the $265 million in increased payments from CMS as a result of increased risk score, actually about 2/3 of that is captured by other MA insurers. And so in some sense, because United isn't or doesn't engage in foreclosure, most of the increased benefits of risk scoring are actually captured by the rival insurance plans. And so in summary, we find really no evidence of rival foreclosure, no change in patient composition, no change in quality, but pretty important changes in risk score. And the benefits of that increase in risk scores, about 2/3 of it are captured by other MA plans. And so this has, I think, pretty important implications for both how we pay for Medicare Advantage. I think there's also an important spillover to the Medicare population or the traditional Medicare population in terms of increased benchmarks, and also something that we might want to think about when we think about the antitrust implications of vertical integration in this market. So, thank you.
And as we load the slides for our last presenter of the Egg Timer session, let me just remind you, you can engage with Chris during the long break up here at this door. And for our last Egg Timer of this session, we're very happy to have Julian Reif.
Okay. Thanks for inviting me to present my work on the effects of deleting medical debt from consumer credit reports. This is joint with Victor Duarte, Julia Fonseca, and Divij Kohli. There's been a lot of discussion surrounding the amount of medical debt held by Americans, together with the common practice of having it listed on consumer credit reports. So as of 2022, there was about $70 billion of medical debt listed on credit reports, with about 20% of this coming from small debts under $500. So this has raised concerns from many policymakers about what effects this reporting practice might have on people's access to credit. Now, medical debt is not the only form of debt that's listed on your credit report. These reports also contain information on student loans, unpaid cell phone bills, and so on. But medical debt is arguably unique in that it's often highly inaccurate, reflecting, for example, bills that have already been paid, and it's seldom repaid in full. So in fact, you can purchase medical debt on the secondary market for pennies on the dollar. So it's not clear whether medical debt is particularly relevant or important for assessing credit risk. I think the best prior evidence we have on this question comes from Klunder et al.'s experimental study on medical debt forgiveness. So while they find no effect on average from debt relief, they do find some modest improvements in credit scores for the subsample of individuals whose medical debt would have appeared on credit reports. So this suggests that perhaps removing medical debt from credit reports, as policymakers have long advocated, might improve credit outcomes. And in fact, this is exactly what happened recently. In April of 2023, the credit bureaus stopped reporting medical debts under $500, which dramatically reduced the amount of medical debt on credit reports. And this might not be the end of the story. In January of 2025, the Consumer Financial Protection Bureau announced a proposal to remove all medical debts from credit reports, but this was struck down in July by the courts. And under the new administration, the CFPB has declined to pursue this proposal. So this upset a lot of people. including a large group of 30 senators who wrote an angry letter complaining that medical debt is inaccurate and that listing it on credit reports blocks working families from access to credit. So with all of that as backdrop, our paper sets out to do two things. So first, we use a regressionist continuity design to estimate the causal effect of removing these small medical debts from credit reports. And second, we build credit scoring models to try to understand whether medical debt helps predict default. So by way of background, there's at least three different ways that removing medical debt from credit reports could affect credit outcomes. So first, the removal could raise commercial credit scores such as FICO, which are frequently used by small lenders when making credit decisions. Second, the removal could also affect decisions made by large lenders who typically use their own proprietary underwriting models that are based or that draw on the underlying variables on the credit report. And then finally, the removal might also affect repayment incentives, because debt collectors can now no longer threaten to report these small medical debts to the credit bureaus. So unfortunately, there's no consensus in the literature regarding what is the best way to measure credit access. So our strategy in this paper will be to examine as many downstream credit outcomes as possible. So we're going to do this using data from the GEIS Consumer and Small Business Credit Panel, or GCCP for short. These data include a 1% random sample of people with credit reports from one of the major credit bureaus. So in addition to all of the standard variables and information that's available on the credit report, we have also linked to these data at the individual level to alternative credit records, such as payday loans, which will allow us to construct a broader set of measures of credit access. So the data set itself consists of annual snapshots of about 2.5 million people going back to 2004. Our analysis is going to focus today on the 2019 to 2024 period. We've also extended it to 2025 in our paper. In the data set, we're going to classify a debt collection as medical if either the creditor or the furnisher operates in the healthcare sector. So our analysis will implement a regressionist continuity design around this $500 reporting threshold. This will be a totally standard local linear regression with robust bias-corrected confidence intervals. As I mentioned, these small medical debts were removed from credit reports around April of 2023. So we're going to, for our running variable, we're going to then measure medical debt balances as of April 2022. And then we will measure our main outcomes in April of 2024, so roughly 1 year following deletion. So the main identifying assumption here is a standard RD1, that assignments to either side of the cutoff is as good as random. Here is what our first stage looks like when we measure it at the account level. So as you can see, nearly all medical debts under $500 as of 2022 have been removed from credit reports in 2024. This is what the first stage looks like if you measure it at the person level, which we can do by taking the account data and collapsing it down to one observation per person, using the maximum observed balance across all of the individual's medical debt collections. So in this person level RD, we estimate that individuals just below the cutoff have about 60% fewer medical debts than individuals above the cutoff. The reason it doesn't fall all the way to zero is because the running variable is measured in 2022, and some of these individuals go on to gain medical or accrue medical debts above $500 in the subsequent 2 years. All right, so now on to the main outcomes. We estimate a precise null for credit scores. Our 95% confidence interval rules out that removing all small medical debts raises your Vantage score by 5.5 points or more. That's a relative effect of 0.89% or more. We also estimate a precise null for total credit balances, ruling out increases of 5% or more. We estimate a null effect for total credit card limits. Here, our estimate is a little bit noisier. We can only rule out increases of 21% or more. And then finally, we also rule out a decline in the use of alternative borrowing, such as payday loans, by 7.9% or more. So I don't have time to show you all of our other outcomes. You're just going to have to trust me that they are null as well. These nulls do pose a bit of a puzzle. Normally, we would expect that removing negative information from credit reports would improve people's credit outcomes. So one explanation for this is perhaps medical debts don't provide any useful information to lenders. So to explore that hypothesis, in the second part of our paper, we build credit scoring models. So the results I show you today will be using XGBoost, a machine learning algorithm. So specifically, using data from 2019, we will train the model to predict default, which we define following the literature as having any account 90 or more days past due within the subsequent 2 years. All right, so the basic idea here is really simple. We're going to compare two otherwise identical models, one that includes balance and count information for small medical debts, and a second model that excludes those variables. We're then going to compare the model performance to understand whether or not medical debts are helpful for predicting default. Here are those results. Column 1 shows performance metrics for the model that has all of the predictors. The second column shows you the metrics for the model that excludes small medical debts. So I'm a little bit old school, so I'm going to focus on false negative and false positive rates. We also report, some fancier metrics here as well. It doesn't matter which one you look at. They all tell the same story. The difference in performance between these two models is negligible. And in fact, even if you remove all medical debts from the model, there is no effect on model performance. And so this tells us that medical debts don't provide any incremental predictive power for default risk. To sum up, we find that in an RD design that removing small medical debts from consumer reports didn't have any detectable effects on credit outcomes, and that neither small nor large medical debts appear to have any incremental predictive value for default risk. And so in terms of policy implications, our results suggest that removing all medical debts from credit reports, as some policymakers have advocated, seems unlikely to have an effect on credit access. Thank you.
Thank you very much, Julian. So we now have a break until past. Let me encourage you to engage with any of our egg timer sessions and a final Emily, is this you?
You know, there's like one play that's every year, that's like the entire problem.
There's still 35 seconds you can chat.
Oh, good, okay, hold on. Good. 35. How's Copenhagen? Good, wonderful.
You're not doing another meeting tomorrow?
I want to do, so we're supposed to go to Stockholm, Austria, Israel, Italy this summer.
Yeah.
Hey, you said yes in February.
Okay, thanks everyone for coming back on time.
It's like,
We have one paper between now and lunch. So let's go ahead and invite, we're very happy to have Hong Yuan Jia here with co-author team, and you have 5 minutes completely uninterrupted.
All right. Good morning, and thank you for including our paper into the very nice program. I'm Hong Yuan from Cornell. This is a joint work with Panna from Wisconsin and Tierney from Rochester. It's about pharmaceutical innovation. Since the Second World War, the policies and economics literatures have largely taken for granted a very clear hierarchy of pharmaceutical innovation. In that hierarchy, US sits at the top as a leader. It produces way more innovative drugs than any other countries, as you can see in this figure. Europe and Japan, they are very strong second tier, but developing countries, they are mostly free riders. They consume innovation, they produce generics, but they're never expected to contribute to the global pipeline of innovative drugs. This narrative, the hierarchy, is not only deeply embedded in policies, but also in these very influential economics papers. However, the hierarchy is changing. A very different story about the rise of drug industry in China has started to emerge. If you go to the media like New York Times, you'll find these headlines. These headlines suggest that the drug industry in China is having a DeepSeek moment. It is starting to generate its own innovative therapies rather than just produce generics or provide manufacturing capacity. For example, Tevibra is a drug developed by Beijing, a Chinese firm. It has already been approved by FDA as a first-line treatment for esophageal cancer, extending median survival from 10 months to 17 months for US patients. At the same time, there is much skepticism. A common counter-argument is that the advances in China are just some copycat activities or me-too drugs designed to capture domestic market share instead of pushing the global knowledge frontier. So, in this paper, we take one step back and ask 3 research questions. First, can a developing country like China move from a receiver to a contributor of biomedical innovation? If we take China seriously as a case study over the past 20 years, do we see a genuine transition from a follower to an innovator? Or are we observing more of the same copycat activities at a larger scale? Second, if the transition is real, why could that happen? Is it something we should expect from the rapid economic growth, or is it the result of some deliberate policy reforms, especially the reforms in the healthcare sector? Understanding these mechanisms can provide broader insights beyond China about how economic forces and policy choices can stimulate innovation. This is particularly important at a time with growing concern about the declining innovation in the US and Europe. Third, what are the welfare implications of this transition? How does this transition benefit patients in the US and around the world? To answer these 3 questions, we assemble very comprehensive data, and here is a preview of what we do and what we find. We first document that China has caught up across the entire pipeline of drug development process. We observe growth not only in early-stage clinical trials, but also in later milestone events such as licensing to international firms and new drug approvals. Second, the trial increase is not only about quantity. Using 3 different measures of novelty, we show the trial growth is also in quality. Third, the transition is mostly driven by the private investment from China headquartered firms. It is not merely the reallocation of clinical trial activities from the US to China. The second thing we do is to unpack the behind mechanisms and answer the question why. We use disease country year level variation and horse race both demand side and supply side factors. Our main finding is that the NRDL reform, National Reimbursement Drug List reform, which expands the effective market size and trigger a large R&D response, is a key driver. This reform explains 59% of oncology trial growth. Other important factors include knowledge creation and talent flow and venture capital investment. Both factors explain around 20% separately, but these 2 factors cannot attenuate the NRDL effects. We also examine other policies and subsidy programs, but they have relatively smaller effects in our decomposition analysis. The third thing we do is to analyze the welfare implications of the NRDL reform. Our back-of-envelope calculation yields 2 main findings. First, for China, the dynamic social surplus from innovation is about 3 times of the static social surplus from the expanded patient access. Second, for the world, these innovative drugs can have international spillovers once they are approved and used in other countries, just like the earlier Vibra example. This international spillover in our estimation is at least 4 times as large as the domestic gains from innovation. This paper speaks to 3 strands of literature: market size and innovation, firms' incentives in R&D, industrial policy, and innovation. Our main contribution is to show that the effective market size expansion driven by the insurance design can be a very important policy lever for innovation. And such a demand pool policy can trigger really novel innovations rather than just marginal ones. Moreover, we are the first paper in the literature that systematically document the rise of pharmaceutical innovation in China and comprehensively examine both demand side and supply side drivers. This is a big picture of our paper. Before I go to the data and the empirical part, let me briefly talk about the institutional context. The Chinese healthcare system, the public health insurance program, covers 95% of the population in China. Private insurance, by contrast, remains very limited. As a result, the government is not only the principal insurer, but also the dominant purchaser of healthcare services and pharmaceuticals, with spending more than $74 billion in 2022. Therefore, being included in the public reimbursement list is a very important gateway to the Chinese pharmaceutical market. Historically, however, innovative drugs are largely excluded, and this system prioritized coverage of generic drugs. Despite the difference in the healthcare system, the drug development process in China is very similar to that of the US. Phase 1 tests safety and dosage. Phase 2 provides preliminary evidence about efficacy. Phase 3 is large-scale RCT that leads to the final approval. The whole process is costly, lengthy, and risky. So some firms choose to out-license their successful compound rather than develop it to the approval. To examine the 3 research questions in this paper, we assemble very comprehensive data. Our data spans from 2010 to 2024, with one exception. For drug sales data, we only have it from 2017 to 2024. We start from the clinical trials data. Trial12 provides near comprehensive census of clinical trials conducted in China, US, and globally. with trial information about tested target, diseases, timing, stage of each trial. Pharma projects allow us to track patenting before the trial and subsequent drug development milestones such as licensing and approval. To examine different mechanisms, we assemble very comprehensive data. Signal Health provides drug sales data, allow us to measure the effective market size expansion. OpenAlex contains publications data that allow us to measure the upstream knowledge creation. PitchBook captures venture capital investment, and the IHME measures the disease burden. We also scrape the data from State Policy Library of China so that we can track all the biopharmaceutical policies in China over time. Once we get this data and construct the measures, we'll link this data together by a disease country year taxonomy. This integrated structure allows us to examine both demand side and supply side factors within a unified framework. Once the data is ready, we'll start to answer the first question. Can a developing country like China transit from a follower to an innovator? In this figure, we show the surge of clinical trial activities in China. As you can see in this figure, before 2016, the clinical trial activity in China is largely parallel to that of the US or Europe. But after 2016, the trial activity in China experienced a sharp surge. And around 2020, China has surpassed the US and produced more clinical trials. This trend continues, and in 2024, China produced 1,500 more clinical trials than that of the US. Yes.
Pardon my ignorance on this. Can you just say how patents and patent enforcement and civil litigation and like how all of that works in China relative to the US? Like, is it mostly similar? Is it much harder to sue? Are patents shorter? Is there more corruption in getting around patent violations? Kind of how similar is this to the US and how different?
Thank you for this question. We'll talk about more mechanisms later, but for patenting, we do not examine that much. But in general, it's very similar, and there are two big shocks in 2008 and 2020, which is not covered in this period, but definitely we can talk more about that after. Yeah.
Thanks.
Yes.
Are you going to talk about how many of the kind of trials in the increase are duplicative? So kind of duplicating trials that happened in US and Europe versus kind of new drugs?
What do you mean by seeing duplicated trials? Like they conducted both in Europe and China, or?
Yeah, exactly. I guess what I have in mind is something almost a little different. There's so few trials before. You might wonder that a lot of the increase is just a catch up or a backlog testing stuff that was already being tested before. And so I'm just kind of curious how much of the uptick is that versus actually kind of similar new drugs.
Yeah, thank you. Actually, I checked the data. There are only 2.5% trials that are conducted both in China and the US, which is a bigger sample of what you claim. And these trials are many sponsored by Chinese firms. So what you mentioned is relatively a smaller sample in our data. Okay. These things are about clinical trials. It's more like R&D efforts. How about R&D outcomes? In this paper, we examine two R&D outcomes, two milestone events following the successful trials. The first outcome is out-licensing. It happens when other firms, usually international firms, acquire the rights to develop and commercialize a drug. It's usually an indicator of early-stage drug success. As you can see in this figure, before 2016, the number of licensed drugs in China is almost zero. But after 2016, it's gradually increased, and around 2024, the number of licensed drugs by Chinese firms is about 1/3 of the number of licensed drugs by US firms. The second outcome we examine is approval. It's usually the end point of a drug project. It means a drug is authorized by the regulatory agency to enter the market. Here, we only focus on the first approval of each drug globally. As you can see, before 2016, the number of approved drugs by Chinese firms is only several per year. But after 2016, it started to increase. And in 2024, the number of approved drugs by Chinese firms surpassed the US. Yes.
Preference when you have two similar drugs, one by a US firm and one by a Chinese firm that do similar things, to put the Chinese firm drug on the list rather than the US firm drug? I'm trying to understand how much of this I should think about as a global market versus a country-specific market for new pharmaceuticals.
Yeah, thank you for the question. It's actually, we focus on the global market, and one drug can be on the US market or Chinese market, and we only count it once.
But I guess what I'm asking is, in terms of putting it on the list, on the national formulary, like, is there a preference for a Chinese firm drug versus a US firm drug that do similar things? If they're choosing, I'm only going to put one statin on the list, are they going to choose the Chinese firm drug? Because if that's the case, then it's not really a global market, right? Or it's sort of a global market, but not as global as you might think.
Okay, thank you for the question. We'll talk more details about the NRDL and the drug list later. But as far as I know, there is no such kind of preference. Is that right? Yeah. Okay. So these are some descriptive stats, and these descriptive stats show that the China has caught up not only in R&D efforts, but also in these R&D outcomes. Then we'll move to the more causal analysis. Our event study is at disease country year level. Yes. Thank you. We'll talk about that later. In 2017, China joined the ICH, and we'll come to that like in 10 minutes. Our dependent variable is the log number of clinical trials conducted at disease country year level. We have 312 diseases, which is very granular. We have two key independent variables. The first is a treatment indicator, that is trials conducted in China. We take trials conducted in the US as a control group for two reasons. First, US is a frontier. We want to know whether China has caught up with the frontier. Second, the clinical trial activities in the US remains relatively stable over time. Another key independent variable is a pulse indicator. We take 2015 as a benchmark year because the structural break test suggests the regime shift began in 2016. We also add disease by country fixed effects and year fixed effects. In the robustness, we have disease by year fixed effects and country by year fixed effects and Poisson model. The first event study we show is about trial quantity. In this figure, as you can see, the y-axis is a log point. From this figure, we know China conducts 170% more clinical trials for a given disease in 2024 compared to that in 2015 relative to the US. In terms of the raw number, China conducts 6 clinical trials per disease on average in 2015, and it produces 18 clinical trials on average per disease in 2024. For the US, it's relatively stable, producing 10 clinical trials per disease on average across different years. Then we'll move to the event study about quality. We have 3 different measures of novelty. The first novelty measure is based on Journal et al. 2022 paper, and the intuition is simple. Each clinical trial tests a biological mechanism or target. Novel trials are those exploring infrequently studied targets or mechanisms. We calculate the novelty score based on this intuition, and we take trials with novelty score greater than the global median as novel trials. As you can see in this figure, novel trials increased 123% in 2024 compared to that in 2015 relative to the US. We also have an extreme case where the novelty score equal to 1, that is the first in-class drug all over the world, and the results are very similar. Yes?
This is a question from Shushan Danagulian, whose flight was canceled. US and European drugs are severely under-tested among Asian patient populations. To what extent is this existing drugs tested in in different populations, or new drugs specifically designed for different patient populations, as opposed to just regular stochastic drug development?
All right, thank you. Later in the mechanism part, we'll show much heterogeneity across different diseases. And we'll see that this reform, which we'll mention that later, will target some diseases that has very high prevalence rate in China.
Great.
Thank you. And we also have two alternative measures of novelty. In the first alternative novelty measure, we exclude all generic trials. The trials left are those investigating new targets, new indication, new molecules, or new combinations. The second alternative measure is a very demanding measure. We only focus on phase 3 trials. Phase 3 trials are large-scale RCTs with a treatment group that is usually the tested drug and a control group that could be an innovative drug, a generic drug, or a placebo group. If the firm choose to test this drug, their own drug, against the innovation frontier, the innovative drug, it means the trial should be of higher quality. And as you can see, both measures show very consistent results. Yes.
I guess one other version of this that would be nice to see is like what share of the drugs then had a trial not in China. What share of them actually showed up on the European or US market at some point, which would tell us something about substitutability with drugs that are on those markets.
Yeah, very interesting. We can incorporate that analysis. That might be another paper, actually. Thank you. Yeah. So from this event study, we see that the surge in clinical trials is not only in quantity, but also in quality. But who conducts these clinical trials? Here, we split trials conducted in China by sponsor or firm nationality. As you can see, the blue line, it shows trials conducted in China by Chinese firms increased 200%. But the red line shows that the trial increase by international firms does not increase that much. This finding suggests that the trial increase of what we observe is not simply the reallocation of multinational corporations' trial activities. Instead, it's more like the genuine intrinsic increase in the innovation capacity in China. And our results are robust across different specifications. We have trials conducted in Europe as a control group. We have different fixed effect model and Poisson model. In particular, I want to show you one result about different phases. As you can see in this figure, yes. Thank you for the question. We haven't dived that further to examine this kind of firm acquisition, but in the Citeline data, they typically report the final firm, not the subsidiary or the acquired stuff. Yeah. Okay, so in this figure, we show that phase 1 clinical trials react immediately right after 2015, phase 2 trials wait 1 or 2 years to increase, and phase 3 trials wait like 3 to 4 years, and they started to increase starting from 2019 or 2020. This is a very natural progression of the trial increase. So far, from this test, we know that China has caught up, not only in clinical trials, but also in later milestone events. We observe surge not only in quantity, but also in quality, and this is mainly driven by domestic Chinese firms. Then we'll start to examine mechanisms. In this paper, we examine both demand side and supply side factors, and here is a list of what we examine. The first mechanism we examine, and it's also the main mechanism we argue in this paper, is the NRDL reform. Before 2016, the National Reimbursement Drug List, the formulary, prioritized the coverage of generic drugs. Innovative drugs are largely excluded from the formulary. As a result, even approved innovative drugs remain on the private market with very limited access to patients. However, The reform in 2016 changed the system by coupling centralized negotiation with formulary expansion. In each annual round, the eligibility selectively favors innovative drugs, and firms that negotiate successfully will accept a significant price reduction in exchange for insurance coverage and access to a very large patient population. If the negotiation fails, it's fine, the drug can remain on the private market. Therefore, this shock introduced a price-quantity trade-off. In this slide, we show the effects of NRDL inclusion on drug price and revenues in China. Here we compare included drug versus excluded drug using a staggered roll-out DID design. And as you can see from the left-hand side figure, after the drug is included in the NRDL, the price goes down by 50 to 60%. But as shown in the right-hand side, the revenue goes up. On average, the revenue doubled. And for some drugs, like oncology drugs, the revenue increased 500%. Since the marginal cost is very low, much of the revenue goes to producer surplus. How about NRDL effects on innovation? In this figure, we show the raw correlation between the disease level NRDL exposure and the disease level changes in the number of clinical trials. The x-axis is the number of NRDL included drugs included throughout the period from 2016 to 2024. And the y-axis is the changes in the number of clinical trials at the disease level. The intuition is simple. Some diseases may experience a larger expansion of reimbursed drugs and revenues after the reform. As you can see, there is much heterogeneity across different diseases in terms of the NRDL exposure. Some of the most exposed diseases are lung cancer, liver cancer, and renal cancer. Another important observation from this figure is that diseases that experience more NRDL expansion, they also experience a bigger increase in the number of clinical trials. Yes.
How do I think about the NRDL being exogenous here? So if the exposure or the number of available drugs to get covered is, a consequence of an ongoing innovative process, and you're just observing the lagged outcomes of this innovation process, can we actually think of it as the NRDL's causal impact on this, or?
Thank you for the question. Later we'll discuss the endogeneity part, and we'll have two instruments variable. Yeah, in 2 or 3 pages. We further quantify this positive correlation using the disease country year level variation. As you can see here, we have 4 different NRDL exposure measures: log number of NRDL included drugs, log revenue of NRDL included drugs, the ratio of NRDL included drugs, that is, the number of NRDL included drug over the total number of drugs in that disease, and the ratio of NRDL included drug revenue, that is, the revenue of the NRDL included drug over the total revenue. All these variables are at disease country year level. As you can see, these 4 measures show very consistent positive correlation between NRDL exposure and the trial numbers. In other words, diseases experience more NRDL exposure also experience a larger clinical trial increase. However, correlation is not causation. The NRDL exposure is not randomly assigned across different diseases, and the direction of the bias is unclear. On the one hand, NRDL may target diseases with much innovation potential. This will induce upward bias. On the other hand, NRDL may target diseases with much unmet medical needs or low prior commercial incentives. This will induce downward bias. To deal with these 2 concerns, in this paper, we have 2 shift share instrument variables. The first is a demand-side instrument. It interacts the disease level demand elasticity with the annual NRDL expenditure. We estimate the demand elasticity at the disease level using price quantity responses to the NRDL reform. And the intuition is simple. After the NRDL expansion, diseases with more elastic demand will experience a larger expansion of the market size, and therefore they have a larger NRDL exposure. The second is a supply-side instrument. It interacts the number of innovative drugs approved in the US before the shock with the annual NRDL expenditure. The intuition is that diseases with a large pre-shock stock of globally innovative therapies can have more drugs that could be subsequently be included in the reimbursement list. And the IV estimation results, as you can see, are very consistent with the OLS estimation results, show the positive correlation, and the results are larger than the OLS estimation results. The estimated trial elasticity with respect to revenue is about 0.21, which is very comparable to Dubal et al. 2015 paper that is 0.23 using OECD data. We also have two placebo tests. In the first placebo test, we only focus on diseases without NRDL exposure. If we believe NRDL exposure is the main driver, these diseases, they do not have any drug included in the reimbursement list throughout the period, and they do not experience any meaningful market expansion driven by NRDL. So we should observe there is no significant increase in clinical trials of these diseases. This is exactly what we find. The second placebo test, we focus on European trials in diseases with NRDL exposure. There is concern that the NRDL exposure is related with global innovation potential. If that's the case, we should observe similar increase in European trials, but we do not find that. So this is about the NRDL reform. It expands the effective market size, trigger a large R&D response, and we show it trigger much clinical trial increase. If we put this mechanism in the joint regression with other factors, we find a 10% increase in the NRDL exposure, increase 6.7% more clinical trials per disease country year level. And the average number per disease country year is 10. The second mechanism we examine is about knowledge accumulation and talent flow. We measure knowledge accumulation using number of papers published in each year from OpenAlex. We only focus on biomedical papers. As you can see on the left-hand side, the number of papers in China is largely parallel to that of the US, gradually increase, and there is no trend break around 2016. And we also use the paper stock over the past 3 or 5 years as a robustness in our paper. And the second measure is scientists with US experience. We measure US experience using scientists with at least 3 papers under a US affiliation. As you can see in this figure, in the blue line on the right-hand side, the number of scientists who have US experience and come back to China is increasing across year. But again, there is no trend break around 2016. In other words, they may not be able to explain the sudden surge around 2016. And if we put this factor in the joint regression, you'll see 100 additional papers will increase 2.4% more clinical trials per disease country year. The third factor we examine is venture capital investment, which provides funding to clinical trials. And as you can see, the venture capital activities in China is largely parallel to that of the US, and there is a significant decline after 2021. This might reflect the global capital market change. Again, this factor may not be able to explain the sustained growth even after 2021. If we put the factor in the joint regression, we'll see 100 million more venture capital investment per disease will increase 7.3% more clinical trials. The fourth factor we examine is application reform, which reduces the backlog days. In 2015, China has an application reform which try to make the application process faster. Here, as you can see, we show the time variation of the average IND backlog days. IND backlog days are the days between the submission and approval of the investigational new drug application, which is a starting point of a clinical trial. As you can see, the backlog days decreased from more than a year before 2015 to less than 1 or 2 months in 2018 or 2019. However, this is a one-time shock in 2015. It cannot explain the growth even after 2019. And if we put it in a joint regression, we find the 1 month additional backlog days decrease 0.9% of oncology or of clinical trials. And the fifth factor is related to earlier question. It's about ICH harmonization. In 2017, China joined the International Council for Harmonization of Technical Requirements for Pharmaceuticals for Human Use. This change aligns the drug regulatory process of China with the global standards and make the trials conducted in China be more recognized by the global market and potentially can expand the market size of these clinical trials conducted in China. As you can see, here we proxy the global market size using the US prevalence rate for each disease. And we also have a robustness check using the global prevalence rate. And we interacted with a post indicator. However, the coefficient is not significant and is very small. We also examine other industrial policies and innovations, but many of these policies apply to different diseases, and they may not be able to explain the disease level variation or heterogeneity as what we observed in the trial growth. And if we put this policy in the joint regression, we find one additional policy increased 0.3% more clinical trials per disease country year. So if we put all these factors together and do the decomposition analysis, we'll find the NRDL is a primary driver. It explains 59% of oncology trial growth, following by knowledge and talent and venture capital investment. Both explains about 20%. Other factors remains modest. So far, we have answered the second question about the mechanism. Our main argument is that the increase behind the trial growth in China is mainly driven by the NRDL reform. Then we'll start to answer the third question of this paper about the welfare implication. Our back-of-envelope calculation aim to quantify static versus dynamic and international gains from the NRDL expansion. The static gains arise from the welfare from lower price of existing drug after the NRDL reform. NRDL reform reduced the price of innovative drugs through negotiation and provide expanded access to patients about these innovative drugs. This can increase consumer surplus. Moreover, the reduced price of innovative drugs can also mitigate the market distortion of these innovative drugs. So this is about static gains. Dynamic gains arise from new drugs induced by the reform. As we show in this paper, NRDL reform trigger a large R&D response from firms. Firms conduct more clinical trials, and these clinical trials, if they become successful in the future, they'll become new drugs, and these new drugs can increase the consumer surplus. Third, it's about the international spillover. Just as what we mentioned before about the Tevibra, if this new drug being approved and used in the global market, not only Chinese patients, but also the patients all over the world can benefit from these new drugs. We implement these ideas in the back-of-envelope welfare calculation, and here we show the consumer surplus, that is a blue bar, government spending, that is a pink bar, the producer surplus, that is a green bar, and the social surplus, that is a light blue bar. And as you can see here, the dynamic social surplus from innovation is about 3 times of the static social surplus from expanded patient access. And the dynamic consumer surplus is about 2 times of the static consumer surplus. If we take the international spillover into consideration, in this figure, we'll find the international consumer surplus, which is from the drugs developed in China but used in other countries, is about 4 times as large as the dynamic social surplus. Innovation is not only for China, it's for the world. Conclusion. In this paper, we show that China has shifted from a follower to an active contributor in biopharmaceutical innovation. This surge is not only in quantity, but also in quality. We examine different mechanisms, and we find the demand pull policy is a primary driver. Other factors, knowledge creation and talent flow, and venture capital investment, they also matter. And this paper also provides a new perspective on evaluating healthcare policies. Patient access is important, but innovation is at least as important as patient access. Moreover, innovation is not only for one country, it can have international spillover for the world. That's it. Thank you.
So it was so efficient. We have about 5 minutes for questions.
Yes.
I have one question about your measure of novelty. If I understood correctly, that measure of novelty was related to how many times the target and kind of like the action or channel was tested before.
Yeah.
But you could think how this could actually be a result of something or a drug or a component that was held by someone with, or like with an entity with a high market power,
yeah,
or like with a patent, not necessarily like a measure of novelty.
Yeah.
Is there a way in which you could actually measure like something that is more factual about the novelty of the component that is being tested? I don't know, molecular closeness or something that really tells us like this is something that has never been tested before in the actual components, not just like not tested before because other reasons that will be related with like consumer surplus,
yeah,
just because like eliminating market power and those markups or things like that.
Yeah, thank you for the question. Actually, we have the first in class result, which is exactly what you mentioned. And yeah.
Yeah, please.
Thank you. I have 2 questions, one on mechanism. My understanding of the Chinese reimbursement policy is that approximately 40% of the medicines covered are traditional Chinese medicines, not what we would consider to be medicines. So I don't completely understand, and I looked in your paper, it looks like you include those in your sample. So I don't completely understand how that really relates to global innovation when we have a very different definition of than the US and Europe has a very different definition of medicine than China does. And secondly, I have a question about your results on clinical trials. I would think that the lower bar would drive many more phase 1 trials than phase 3 trials.
Yep.
And so can you explain that as well? Thank you.
In our heterogeneity result, I can first answer the second question, and I guess Kenny can help with the first question. For the heterogeneity across different phases, as what I show in the heterogeneity part, phase 1 reacts immediately, and it has a larger magnitude. The reason is that phase 1 trial is cheaper, and phase 3 trials are very, very expensive. And also, these phase 3 trials could be some subsequent results of the phase 1 trial, some, progression of this stuff. That's for the second question. And for the first question.
They're all chemical drugs. We excluded the traditional Chinese medicine stuff. So you see all chemical drugs. What's that?
In your paper, they look
Okay. We have a chat. I think we excluded Any other questions for our? Please.
I respond?
Please, absolutely.
Okay, so just a few quick comments. The first is, China's patent system changed drastically in 2021 and very similar, to the setting in the US. We control for country year fixed effects. And second, China joined the ICH in 2017. So technically trials conducted in China are recognized or at least by the same international standard as here. But usually we don't see a lot of acquisition yet. And the common practice is for the trial companies after the successful trial to license the commercial rights to multinationals, particularly for commercial rights to sell the drug in US and Europe, and retain the commercial rights in China. And that is what, Hongyuan showed that has been increasing significantly. That's what the media is all about, that the US firms are now going to China to buy the successful trials. And second, for the US trials not tested in China, those are, so we show that majority of the trials are taken by Chinese headquartered firms. So they are not US firms trying to conduct trials on existing drugs. The fourth, NRDL was not motivated by innovation. It was really a response to the public request for coverage of innovative drugs and primarily cancer drugs. So the initial motivation of the policy is just to help patients access to innovative drugs developed worldwide. So in the earlier sample period, the majority of the drugs are international drugs. I think it's 60-40 split. And later on, the government recognized that this expanded market size significantly for innovative drugs as a result can stimulate innovation, which is the paper with Ashley, we showed that the patient access is phenomenal. And here, we're basically showing that the innovative drugs potentially as the hit market could be even more important through the dynamic efficiency gains. And the traditional drugs, those are not included in our analysis. Okay, so it is true, but the most important part of the national reimbursement list is that there's the generic version, which is, here we focus on innovative drugs that are patented within 5 years. The other sector, which is also pretty large, are drugs that are already off patent, generic, or traditional, Chinese drugs. So that's a different sector. We're not including this analysis, but we'll be including a paper, follow-up paper with Ashley, where we look at innovation policy design.
Thank you. We are at time. So one more round of applause for our presenter team. I am sure that the author team will be happy to stick around and answer your questions. We now break for lunch. We're starting again at 15 past the next hour. Let me just say that the lunchroom is
If it should work.
Welcome back, folks. Thanks for coming back on time. There's plenty of seats up at the table. Feel free to move closer if you would like to join us. This will be increasingly true throughout the afternoon, most likely. We're very happy to have Sydney Constantini here from UC Berkeley. You have 5 minutes completely uninterrupted.
Okay, perfect. Thank you so much for having me. I'll start with a brief motivation. So homelessness rates throughout the US and much of the world have reached record highs with around 770,000 unhoused individuals at the end of 2024. And a sizable portion of unhoused individuals suffer from some form of mental illness, including substance use, which is the population I'm going to be focusing on here. So this raises the question for these individuals, is homelessness primarily a housing problem, or is it primarily a substance use or mental health issue? And in particular, when we think about homelessness interventions for this population, should we be targeting what we typically think of as the most salient problem, which is their lack of housing, or perhaps what we would think of as their underlying problem, which is their mental health or substance use condition? And this is exactly what this paper is going to be tackling. It's going to be looking at interventions that emphasize housing and comparing with interventions that emphasize treatment. So what is housing first? So in the 1990s, homelessness advocates developed this concept, and the idea is that highly subsidized permanent housing should be given unconditionally and immediately before any underlying issues such as mental health are addressed. And the philosophy behind the program is that requiring preconditions to housing could just act as a barrier to seeking care. So if you would require people to be sober, for instance, before seeking housing help, they would end up just staying on the streets. A related concern is that it might be difficult to address underlying mental health issues without having a stable home first. So the idea is that once we put people into stable housing, they'll be better able to attend their appointments, for instance, so they'll be able to seek mental health treatment voluntarily on their own. Housing first programs are pitted against programs that instead emphasize housing readiness, or what I'm going to call treatment first. And the philosophy behind these programs is the exact opposite of housing first. It's that mental health and substance use issues need to be addressed before individuals enter permanent housing. So the idea here is that these populations were sometimes considered so severe that they wouldn't even be able to succeed in maintaining their housing unless you address these issues first. Advocates of the treatment first style approach also argue that housing first does not address the root cause of homelessness, which they believe are often these mental health and substance use issues, nor do they incentivize any long-term behavioral changes, since it's just kind of like giving people a house for free. So the idea of these approaches is to kind of put people on a path towards self-sufficiency. These type of treatment first style approaches typically employ what is called transitional housing, or if you're familiar with the term halfway house, that's similar. This is going to be temporary communal housing in which substance use and mental health treatment are generally required, sometimes along with sobriety. So if you don't maintain sobriety, you could actually be kicked out. So individuals would stay in these transitional housing units about a year, after which they would be deemed quote unquote ready to enter more permanent housing, hence the term housing readiness programs. So housing first versus treatment first has gained a lot of attention in the policy debate. So you may have seen this executive order from last summer that the Trump administration issued, entitled Ending Crime and Disorder on America's Streets. In this executive order, the administration calls housing first policies that deprioritize accountability and fail to promote treatment, recovery, and self-sufficiency. So in this executive order, they officially bans federal support for housing first policies, and they're instead promoting treatment first type policies. So in this paper, I'm going to be using data from the Department of Veterans Affairs, who run a national housing first style program and a national treatment first style program, which is going to allow me to directly compare them. The first program I'm going to be looking at is called HUD-VASH. It stands for the Department of Housing and Urban Development and the Department of Veterans Affairs Supportive Housing. So this is going to be the housing first style intervention. The setup of the program is that individuals are going to receive a housing voucher. With that housing voucher, they can select any apartment they want. So these are just going to be normal apartments in the city. And the voucher is going to pay the vast majority of their rent. So if you're familiar with Section 8, this is going to be very similar. So the duration of the program is permanent. You can keep the voucher as long as you need it, and you're only kicked out in extreme circumstances, such as if you were to be incarcerated. And the only requirement of the program is that you agree to case management services, which is essentially just a social worker checking in on you and making sure you're still in your housing unit. So it's a very light touch intervention. I'm going to be comparing this with the VA's grant and per diem program, which is going to be the treatment first style intervention. It's called grant and per diem because the VA contracts out with third-party agencies. So you can think of agencies like the Salvation Army that run transitional housing units where veterans can stay anywhere from 6 months to 2 years. That's how long the VA will pay for you. But in practice, people are staying around 9 months. And the requirements of these programs do differ across organizations since they're third-party administered, but the requirements tend to be much stricter. So most of them really emphasize and require mental health treatment, and some of them even require sobriety. So if you don't adhere to the requirements of the program, you could be kicked out. And after a stay in these transitional housing units, you would just have to find your own housing independently. Okay, so what am I going to do in this paper? I'm going to evaluate the effects of housing first versus treatment first using a national sample of nearly 300,000 unhoused veterans who also have a mental health condition, including substance use. And I'm going to explicitly define 3 treatments for these individuals. The first treatment is going to be the housing voucher through the HUD-VASH program, which is going to be the housing first intervention. The second treatment is going to be transitional housing through the grant and per diem program, which is going to be the treatment first style intervention. And I'll be comparing both of these with having no housing intervention. So from now on, I'll refer to housing first as the voucher program and to treatment first as transitional housing. Obviously, treatment assignment is not random here. So what I'm going to do here is I'm going to use an instrumental variables framework. Importantly, I'm going to have 2 instruments because I have an extra endogenous treatment state. Okay, let me give you a preview of the results. So compared to no intervention, I'm going to find that housing first has quite a large impact on 3-year mortality. So it's going to decrease 3-year mortality by around 4.6 percentage points. In contrast, I'm going to find that transitional housing has an effect size on mortality very close to 0. And I can actually rule out that these 2 effects are the same size. So housing first is more effective than treatment first at reducing mortality. So why is this the case? I'm going to look at some intermediate outcomes to try to disentangle this. First, I'm going to find that housing first massively increases long-term housing stability. So it seems like people are effectively using their vouchers and staying in their homes. It also increases with engagement with VA social workers because people are adhering to this case management program. Interestingly, I find that it has no impact at all on mental health care utilization. So this kind of contradicts the narrative that once people are put into a stable housing unit, they'll voluntarily seek mental health treatment on their own. In contrast, I'm going to find that treatment first has a short-term impact on housing stability, but this is primarily when people are staying in transitional housing units, and this is going to rapidly decline as people exit these units, suggesting that they're not always finding their own permanent housing afterwards. It also has a short-term impact on use of mental health care, because remember, these programs often require mental health treatment, but again, effects are going to fade to 0 over time. So this suggests that even if we require mental health treatment in the short term, it doesn't lead to long-term behavioral changes in terms of people staying attached to mental health care. Another thing we can do to try to get at the mechanisms is look at cause of death. And I find that housing first reduces mortality due to causes explained by both homelessness and drug use. So it reduces mortality due to exposure to the elements, violence, as well as bloodborne infections related to sharing needles. And then finally, did you have a question? You may be wondering if housing first is worth funding relative to treatment first, since housing first is a permanent intervention. So I'm going to look at the costs over the 3-year study period that I can observe it. And the main kind of finding here is that housing first is going to reduce long inpatient mental health stays related to mental health and substance use. And this is actually going to make it cost saving relative to the transitional housing intervention. Yes. Yeah. Yeah, I think that's plausible. I think like it's kind of different because the treatment first is kind of a bundle. It's the short-term housing plus mental health treatment, but you could just think like one program is short-term housing as opposed to one program being permanent housing. I think that's a fair way to think about it, but I think another way to think about it is sort of in terms of costs. So maybe you're thinking like maybe treatment first would be relatively cheap, and so the effectiveness per dollar might be similar, but actually the cost analysis shows that's not the case because in terms of indirect costs, housing first ends up being cheaper. Okay. So this paper contributed to the literature on the effects of housing first. So most of the prior literature has been small RCTs and single sites demonstrating that housing first increases housing stability. This may seem like a kind of mechanical result, but this was actually kind of the open question because people thought this population was so severe that they actually wouldn't be able to maintain their housing. But effects on health have been much less clear. So this is going to be the largest national sample to date on the in-house population, and it's going to be the first to show that there's a causal effect of housing first on mortality. This paper also contributes to essentially non-existent literature that explicitly compares housing first versus treatment first, which is really what the policy debate is about. So most of this prior literature has been, these RCTs have enrolled people in housing first, but the counterfactual has just been this ambiguous no housing first counterfactual, which was usually comprised of individuals who enrolled in transitional housing type interventions, as well as individuals who enrolled in no treatment at all. So to really answer the policy question, we really want to disentangle average treatment effects of the programs, and this is the first paper to do so. Okay, so let me start with the empirical design. So data is going to come from the Department of Veterans Affairs, which provides healthcare and homelessness services to U.S. veterans, and this is primarily going to be for free in this setting. To track the use of homelessness services, I'm going to use the VA's homelessness registry, and then I can link these data to the VA's medical record system. So this is going to have information about all their visits, demographics, as well as very reliable mortality data. And then I can link these data also to National Death Index data on cause of death. Okay, so the sample is going to consist of all individuals with a mental health or substance use condition who had initial intake assessment with VA Homelessness Services between April 2011 and February 7, 2017. And I'm going to define 3 initial mutually exclusive and exhaustive treatment statuses for individual I. So DI is going to be equal to V for getting a housing voucher, T for getting transitional housing, and 0 for getting neither program. And I define this as just the first program an individual enters within 3 months of their intake assessment. So you can just think of this as the initial program that they're referred to. So just to reiterate, there's going to be 3 mutually exclusive treatment states, voucher V, transitional housing T, and neither 0. I'll always show you results for the voucher program in blue and for transitional housing in green. Okay, so here's what the sample characteristics look like. Column 1 shows characteristics for the full sample. Column 2 shows characteristics for those who actually enroll in the voucher program. And column 3 shows characteristics for those who enroll in transitional housing. So let me just point out a few things. So the sample is overwhelmingly male. That's just because these are veterans. The average age is around 50. Rates of depression are extremely high. About half the sample has some kind of substance use condition, so either alcohol or drug use. More than half the sample also has a chronic physical condition. So this would be something like diabetes or heart disease. So you can think of this as a comorbid population. And overall, about 12% of the sample receives a voucher, and about 18% of the sample receives transitional housing. Characteristics of voucher and transitional housing enrollees look somewhat similar to the full sample, except that transitional housing seems slightly more catered towards individuals with substance use, which makes sense because some of these units were sort of sobriety houses, for instance. Okay. So let me give you some context for understanding the empirical design, which is that veterans experiencing housing issues can drop by any VA medical center. So these are in urban areas throughout the country. There's one in Boston. or what are called community resource and referral centers. So these are going to be strategically placed centers in urban areas targeted towards unhoused veterans. So for example, there's one in downtown San Francisco that I visited. So you don't need an appointment to show up to one of these centers. You can just drop by. It sort of like resembles the DMV a little bit, actually. So you can just show up, and then a social worker will conduct intake for you. And then veterans are going to be referred to programs meeting their needs, which is going to include the Housing First and Treatment First intervention. I'm going to consider veteran time of arrival to the clinic to be quasi-random. So the idea is here that you have some shock to your housing stability, the timing of which is difficult to predict, and then you show up to the VA to get help. And this is going to allow me to exploit two sources of variation based on clinic arrival time, which are going to form the two instruments. Okay. So the first instrument I'm going to call the voucher availability instrument, and this is going to increase the probability that you receive a housing voucher. So the context here is that vouchers are notoriously in short supply and they're hard to get. So there's a long waiting list. I can't observe the waiting list directly, but I'm essentially going to use a proxy for the length of the voucher waiting list. So in particular, let ZV, which is going to be the first instrument, be the leave out percent of individuals who receive a housing voucher among those who arrive to the clinic at a similar time as you. So in math, ZV is just going to be the count DV of individuals receiving a housing voucher, excluding your own observation, divided by the count of individuals arriving to the clinic, again, excluding your own observation. So the idea here is just the day you arrive to the clinic, how easy is it to get a voucher? Okay. The second instrument I'm going to call the transitional liaison availability instrument, and this is going to increase the probability that you receive transitional housing. So the context here is that during intake, remember, veterans need to be assessed by a social worker. Often they're assessed by a generalist social worker who will then triage them into different programs. But in other cases, if a specialist social worker is available to see them immediately, they'll see that specialist right away. So in particular, transitional housing liaisons are in charge of managing referrals to transitional housing. So if you see that transitional housing liaison right away, it's essentially going to expedite your referral process, both because they know about certain beds available in particular transitional housing units, and because they could potentially encourage you to enter the program. So if you see that transitional housing liaison right away, it's going to increase the probability that you enter transitional housing. So this is going to be similar to kind of a caseworker random assignment instrument, but in this setting, you're not going to randomly see the transitional housing liaison. You would only see that liaison if you're potentially interested in the program. So instead of using direct assignment, I'm going to use a proxy for availability. So essentially, when you arrive at the clinic, was the transitional housing liaison available to see you or not? So could you have seen them? So the second instrument is just going to be a binary. ZT is going to be equal to 1 if a transitional housing liaison performed any intake assessment in the week you arrived to the clinic, which is just going to be my proxy for them being available. Okay, so let me just give a brief word on the controls. So you can imagine that certain areas and time periods are going to have more high-risk individuals. Yeah. It's just I could play around with it. I think there's not that many people that see the transitional housing liaison. So if I use a day, it's kind of just to smooth it out. If I use a day, it's a little bit too close to a direct assignment. So a week gives better balance, but I could play around with it a bit. That's not a particular reason. Yeah. Okay. So you can imagine that there's a big homelessness crisis going on in San Francisco in a particular year, and that may be correlated with both staffing decisions and voucher allocations. So I'm basically going to control for that. So I'm going to control for VA station, which is going to be the geographic area, kind of like the commuting zone, so like the Boston area, interacted with year, as well as VA station interacted with month, because we may be concerned with seasonality effects here, because maybe people who show up in the winter are different than people who show up in the summer, for instance. Okay, so just to give you a sense of how the instruments are working, let's say voucher availability goes up. This makes people more likely to receive a housing voucher. But in this case, they can come from two different counterfactual treatment states. So under the counterfactual, they may have received transitional housing, but now they receive a housing voucher. Or under the counterfactual, they would have received neither, and now they receive a housing voucher. Similarly, let's say the transitional liaison becomes available. This is going to induce individuals into transitional housing from two potential different counterfactuals. So under the counterfactual, they would have received a voucher and now they receive transitional housing. Or under the counterfactual, they would have received neither and now they receive transitional housing. Okay, so that was the setup. Now let's get into the results. So I'm just going to run two-stage least squares. So this is going to answer the question, how do the voucher program and transitional housing impact mortality over time? So I'll show you the regression results over time. The first two regressions are going to be the first stages. So DV is going to be an indicator for enrolling in the voucher program, DT an indicator for enrolling in transitional housing. On the right-hand side, I'm going to have the two instruments, ZV voucher availability, ZT transitional liaison availability, and then I'm going to have the baseline controls that we talked about. And then the last regression is going to be the reduced form regression, where YI is going to be mortality at different time horizons. So here's what the mortality results look like over time. So on the x-axis, I'm going to have days from the intake assessment. In blue, I'm going to have the effect of the voucher program on mortality over time. And in green, I'm going to have the effect of transitional housing on mortality over time. So you can see that the green dots stay relatively close to zero, while the blue dots are becoming, the effect is becoming stronger over time. So overall, two-stage least squares estimates are going to suggest that housing vouchers, or the housing first intervention, reduce mortality by around 4.6 percentage points at 3 years, while transitional housing looks like it has minimal long-term impacts on health. You may be concerned about the standard errors here. So I can't say for sure that transitional housing has no impact on mortality at all. But what I can say is the p-value of the difference between the two coefficients at 3 years is less than 0.05. So what I can conclude from this is that housing first is more effective than treatment first at reducing mortality. Yes. The baseline mortality is around 7 percentage points. So this is like a giant effect. Yeah. Yes. They have a little bit above average, but less so than you would expect. I think it's like 7.5%. So I thought that was surprising as well. So the effect looks huge. Yeah. Okay. So let's try to understand what's going on. Why is housing first more effective than treatment first at reducing mortality? Okay, so I think there's a few potential explanations that we can just go through one by looking at some intermediate outcomes. So the first potential explanation is just housing. So by reducing the number of days on the streets, housing alone could potentially prevent mortality. A second potential explanation is social worker support, because remember, you agreed to this case management program, so housing first may increase contact with VA social workers who could potentially help in a crisis. And the last potential explanation is the one often espoused by housing first advocates, which is that housing first or housing stability may be a necessary precondition for individuals to seek the care that they need. So once people are put into stable housing units, perhaps they'll voluntarily seek mental health treatment on their own. Okay, so let's start with housing. So housing status is actually a very hard outcome to study. So this is not going to be perfect because it's not systematically recorded in clinical records. But what I'm going to do the best I can is I'm going to use a natural language processing algorithm developed for housing status. And I'm going to analyze all housing-related clinical notes in my sample. So I'm going to categorize each note as stably housed or unstably housed. So why am I using this NLP algorithm? Well, first of all, I can't use AI. It's not allowed. But why am I using this versus just like a keyword matching approach? The main benefit is that the algorithm is going to understand sentence context. So it's going to understand if housing status is hypothetical, like he would like to be in an apartment, but he's not; historical, like he used to be in an apartment, but was evicted; or negated. So if it says the veteran was not homeless, it will also understand that. So then I'm going to aggregate these notes into quarters. So I'm going to categorize an individual as stably housed if they had any stable housing note in the quarter, unstably housed if they had only notes indicating unstable housing, and unknown if they had no housing status clearly documented. I'm going to keep the unknowns in here, partially because I have an ascertainment bias problem, but also because unknown housing status could be a particularly bad outcome in the setting if the social workers can't track you and don't know where you are. So I'm going to run two-stage least squares regressions where stably housed is going to be the left-hand side variable. So the interpretation here is that you're documented as stably housed, and also regressions where unknown housing status is the left-hand side variable over time. Okay. So here's what the housing status results look like. Again, on the x-axis, I'm going to have days from the intake assessment. In blue, I'm going to have the effect of the voucher program on being documented as stably housed over time. And in green, I'm going to have the effect of transitional housing on being documented as stably housed over time. So you can see the results are fairly intuitive. For transitional housing, you can see that it has an immediate large impact. It increases the probability that you're being stably housed by around 30 percentage points. And that's because if you enroll in transitional housing, you can essentially immediately get a bed. You don't have to wait. But you can see that housing stability kind of rapidly declines over time for the transitional housing recipients. So this suggests that people are leaving transitional housing units relatively quickly. And once they leave transitional housing units, they may not be able to find a permanent housing solution for themselves. For the voucher, yeah, go ahead. So these are increases relative. This is not like, so I also have a complier mean. The complier means, so for the voucher program, I reach around 80%. It's because the counterfactual of no intervention, like about half of them find their own housing. Yeah. Yeah. And so for the voucher program, the results are kind of the opposite. At the beginning, it has a much smaller impact on housing stability. And this is because once you enrolling in the program is just being given a housing voucher. So you actually have to go around looking for an apartment yourself, and it might be difficult to find a landlord that's going to actually accept the voucher. But you can see that housing stability increases over time. With around like a 35-40 percentage point increase in housing stability around 6 months. And this stays relatively stable throughout the study period. So overall, we can conclude from this, again, the voucher program is more effective than transitional housing at increasing long-term housing stability. Here are the results for unknown housing status. So you can see that at the beginning, both the voucher program and transitional housing make you much less likely to have unknown housing status. And this is kind of like you're enrolled in the programs, one of the programs, and the social workers know where you are. For the voucher program, this stays relatively stable. So it seems like social workers are continuing to track you. But for the transitional housing, the effect is declining over time. So what this is suggesting is that once people leave transitional housing units, they might kind of go lost to the homelessness support system, and the social workers don't know where you are. So I can't like conclude anything definitively about this, but you can potentially say that it'd be a negative outcome in the setting for people to not know what your housing status is. Okay. So this leads nicely to the next point, which is about social worker support. So this figure is just going to show the effect of the voucher program and transitional housing on having any visit with a VA social worker in years 1, 2, or 3 following the intake assessment. So you can see that the voucher program increases your probability of having a visit with a VA social worker by around 40 percentage points in years 1, 2, and 3. So this suggests that people are kind of staying with the case management system and continuing to have visits with social workers. For the transitional housing program, the effects kind of mimic what we saw in the unknown housing status. So at the beginning, the transitional housing also makes you much more likely to have a visit with a VA social worker, but this effect is declining over time. So this is again suggesting that people are leaving transitional housing units and they're not always continuing to stay in contact with VA social workers. Although you can see in the long run, transitional housing still continues to have quite a large impact on social worker visits. So from this slide, this slide is somewhat suggestive evidence that social worker visits are not a big explanation for the mortality effect. If it was a big explanation for the mortality effect, we would perhaps expect transitional housing to also have an effect on mortality, since it does have a long-term effect on visits with social workers. Okay. You guys are not asking very many questions, actually, so I'm ahead of schedule. Yes.
On this slide, what about employment or family status changes? Do you have
Yeah, so I wish I could see that. That's like the one, the VA data is extremely granular. The only thing I can't see is like employment over time. It's just much better for health outcomes. When I've talked to social workers about this, you should be thinking of this as a primarily disabled population. Like most of the population is not working. And there's been some other papers on permanent supportive housing showing minimal employment effects. Because just the vast majority isn't working. But I can't conclude anything for sure because I can't see it over time. Yeah.
Outcome, you get all worried that the notes might reflect the caseworkers know in which program they're in, rather than reflecting with them in the
Oh,
Living, I know you're in these programs already, you have access to data. I know it's gonna get.
so I can at least say, I mean, potentially, but I can at least say that the NLP algorithm does a pretty good job of picking this up. So the NLP, like if you just say you're enrolled in HUD-VASH or you're enrolled in grant and per diem, that's not gonna, the NLP algorithm is not gonna categorize that as stably housed. You have to say something more like you're actually in an apartment. If the social workers are saying something super ambiguous, maybe the NLP would do a bad job, but I think for the most part, I've accounted for that. Yeah. Yeah, so I did, people have asked me about disability benefits. So one of the thoughts in this setting is that if you're meeting with social workers more often, maybe they would help you sign up for other social programs, and that could be responsible for some of the effect. Surprisingly, I'm not finding any increase. Neither program increases the probability or the amount of disability benefits that you receive, which I was kind of surprised by. I think one way that you could think of this population as potentially different from other populations is that they're already attached to the VA. So they have a diagnosed mental health condition in the pre-period. And so you could think that if you have a different housing first intervention where you're enrolling people for the first time in social programs, then it would have a different effect. But in this setting, I don't see anything. Yeah. Yeah, so that's a good question. I've tried to do stuff like this. I have some results. I don't have it in this slide deck, but you can look at intermediate outcomes like ED visits and inpatient stays. Most of the outcomes that are easy to look at are like utilization outcomes, which are sometimes difficult to interpret because things go in both directions. Like you might use less VA services because you're healthier, or you might use more VA services because you're already in a VA program, so they refer you to more other services. What I will tell you is that this kind of comes up in the cost benefit analysis. I am finding that the Housing First program decreases your length of stay in inpatient facilities, which are mostly inpatient mental health facilities. That's the main thing I'm finding. I'm not finding anything on ED visits, which is a bit surprising. But yeah, if you have any suggestions, I tried to work on this for a while. The best thing I can get at to kind of disentangle the mechanisms a bit more is the cause of death. So I'll show you that too. Joe. Okay. All right, let's look at use of mental health care. So remember, this was kind of a big part of the debate where the Housing First advocates kind of say that housing is a prerequisite to seeking any mental health care. Once you're in a stable housing unit, you'll better be able to attend appointments, for instance. So we should see like a voluntary increase in mental health treatment. Whereas the Treatment First advocates kind of say, no, we really need to require mental health treatment, and that's what these transitional housing units do. Okay. So here are the results of the effect of the voucher program and transitional housing on the count of mental health visits in years 1, 2, and 3 following the intake assessment. So you can see that for transitional housing, it increases your number of mental health visits by an average of 5 visits in the first year. And this is consistent with these programs often requiring mental health treatment. But you can see in years 2 and 3, this effect immediately goes to 0. So this may be a bit surprising. This is and just as a caveat, these individuals will have the same access to mental health treatment because there's this free mental health treatment available at the VA. So you can see in years 2 and 3, it just goes to 0. So this suggests that even if we require mental health treatment in the short term, it doesn't seem to lead to long-term behavioral changes in terms of people staying attached to the mental health care system. Alternatively, for the voucher program, you can see that it has no effect at all on the count of mental health visits in years 1, 2, or 3 following the intake assessment. So this kind of directly contradicts the narrative that once you're put into more stable housing, you'll voluntarily seek mental health treatment on your own. That doesn't seem to be going on. Yeah, go ahead. So there's also outpatient clinics. Yeah, that's a good question. So the baseline rate, so I guess the baseline rate I think might change your interpretation a little bit, which is that I think the average number of visits across the sample in the first year is about 10 visits. So you could think of this population as like slightly more attached to mental health care already. So that could potentially change your interpretation. In terms of getting to a VA outpatient clinic? That's a good question. I don't know if I have a great answer to it. There are a lot of outpatient clinics, but of course, like this population may be particularly sensitive to being able to travel places and stuff. So that could potentially be a concern, although both these populations are going to be attached to social workers who could potentially facilitate getting them mental health appointments, etc. Yeah.
As the VA population ages, a lot of the mortality is cardiovascular, and I was
Yeah.
wondering if you saw differences by age or by condition. Because part of what I'm having trouble wrapping my head around is the 30 percentage point increase in housing resulting in a 60% reduction in mortality. You know, it doesn't add up. It's not the effect of housing, it's the effect of being enrolled in a housing program. Because it is also benefiting people who in the counterfactual would have found housing.
I see. So okay, you just think the mortality effect's too big. Okay, I think about that. I mean, so what I can say about cause of death is I'll show you, actually that's the next section. I'll show you the cause of death results. It looks like about half the mortality effect is coming from causes that are clearly associated with homelessness and drug use. So it's actually like very rare causes of death that are leading to these results. So it's stuff like dying from the cold. So it seems very, very related. But I haven't checked cardiovascular causes of death specifically, but I can do that. Yeah. That's just descriptively, yeah. Yeah. Oh, I can do that. Yeah, I think a conditional on the, oh, I actually have a balance table. I thought I would have not enough time. The balance looks really good across, I tested like 40 different X's and they're basically all balanced. So yeah, the balance of the instruments is very good. Yeah. I tried to look at prescription drugs a bit. I was trying to do something like, are you more adherent to mental health drugs? Is that what you were thinking? So I'm not finding reduction in overdose deaths, actually. That's very underpowered. But I've tried to look a little bit at prescriptions, maybe not exactly what you said. I wasn't finding that much in terms of improved adherence to like antidepressants or anything like that. Yeah. Okay. Okay. So now we can look at cause of death since the questions were kind of about this anyway. So what are veterans dying from? This is kind of can also help us disentangle what's going on here. So there's a few potential hypotheses based on what we've seen so far. The first one is that the mortality effect could, again, just be directly related to housing. If this was the case, we would expect potentially a decline in mortality due to exposure to the cold, as well as due to violence, because something that gets talked about in the homelessness literature is that those people who are living on the streets are very exposed to being attacked. A second potential explanation is that mental health and drug use outcomes could be improving among those with housing. This is what some of the questions were about, even without more behavioral health care. So I saw that there was no increases in mental health treatment among the housing first group, but you can imagine that once you're put in a stable housing unit, you start to feel better about your situation, and maybe depression rates would go down on their own, for instance. If this was the case, we may expect suicide or overdose rates to decline, which I'll show you. And the last potential explanation is a kind of an intermediary between the two, which I'm calling a harm reduction explanation, directly kind of from the substance use literature, which is that housing could potentially mitigate risky interactions between drug use and homelessness. So in particular, HIV and hepatitis B and hepatitis C are infections related to needle sharing. So you can live with these infections a long time, even if left untreated, but HIV is going to weaken your immune system over time, and hepatitis B and hepatitis C are going to weaken your liver. So if you develop a new infection, and this could be potentially caused by living on the streets and having poor hygiene, or you continue to abuse alcohol, that could lead to a fatal event. So this suggests that there's a potentially interaction effect between homelessness and drug use, where if you use drugs, but you're doing so indoors, and you have better hygiene, for instance, this could be less risky than using drugs on the streets. Okay. So here are the cause of death results. The first two columns show causes of death that are housing related. The second two columns show causes of death that are mental health related or plausibly mental health related. And column 5 is going to show all other causes of death. So in column 1, I show that the voucher program decreases mortality due to exposure to the elements. In column 2, I show that the voucher program also decreases mortality due to violence or assault. So from these 2 columns, we can kind of definitively conclude that some of the mortality effect is directly related to housing. In column 3, I show a suggestive decline in suicide or overdose deaths, but it's very underpowered. So from this column, I can't say for sure on its own whether mental health and substance use outcomes are improving, or in terms of you just like, having lower depression rates, for instance, or using less drugs. But what I can say in column 4, I show that the voucher program reduces mortality due to HIV, hepatitis B, and hepatitis C. Yeah. Oh, maybe I could. It might be like there's a very small number of people dying from this, but I could separate it. I don't know if it would be underpowered. Yeah, I think that's potential. I'm guessing it's mostly cold, but I'm not sure. Yeah. Yeah, that's a good point. People have asked me like, is there a mortality effect for transitional housing in the first 90 days, but there's not enough people that die at the very beginning to show anything. So it might be a little bit difficult to have it be so granular, but I can try that. Yeah, I think that's a good point. Oh, that's true. Yeah, I could expand it a little bit and do a specific, yeah, that's a good idea. Yeah.
The descriptive group column is the CB0 mean, the control group mean, death rate for that outcome.
Yeah, this is a complier mean, the complier mean for that outcome. Yeah. So you can see that compliers, I guess one difference, what Peter asked before, is that compliers are more likely to die from these rare causes of death than other people in the sample. Yeah, it's a little, the standard errors. I think I should use like a logit or something like that so it doesn't look like more than 100%. But I think my interpretation is that it basically eliminates death from the cold. That's how I would interpret like the first column. Okay, perfect. Okay, so as I was saying before, I do show that the voucher program decreases mortality due to HIV, hepatitis B, and hepatitis C, which is what I was saying before, is consistent with a harm reduction explanation, where if you continue to use drugs, but you do so indoors, it might be safer. And overall, these 4 causes of death that are explicitly related to homelessness or mental health explain about 50% of the mortality effect, even though they're extremely rare outcomes. Okay, so in the very last section, I'll tell you about the budget. So I showed you that housing first is more effective than treatment first at reducing mortality, but a lot of people say it's potentially extremely expensive to give people a house forever. Is it worth doing that? So I can't analyze the cost forever. I know someone's going to tell me one is a permanent intervention and one's not, but I will show you the costs both in terms of direct housing costs as well as indirect costs, like costs of other healthcare visits that I can observe over the three-year study period that I'm following people for both the housing first and treatment first intervention. Okay, so column 1 is going to show the effects of enrolling in the voucher program or HUD-VASH on costs, and I'm going to separate this into various categories. Column 2 is going to show the effects of enrolling in transitional housing or the grant and per diem program on costs. And then column 3, I'm going to show you the difference. So in terms of direct costs, these are just costs of actually like having people be in the housing unit. Obviously, HUD-VASH is going to be somewhat more expensive than grant and per diem since it's a more permanent program, although it's less expensive than maybe you would think because housing people in this transitional housing unit per day is actually going to be more expensive. In terms of social worker visits, again, HUD-VASH is going to be more expensive because people have more case management visits because of the case management program. And then I also am going to look at indirect costs, and this is where things change. So in terms of other homelessness services, this is like people using rapid rehousing, temporary rental assistance, or potentially enrolling in permanent supportive housing later on. You can see that the grant and per diem program increases the cost of other homelessness services by much more, and this is because it's an impermanent intervention. So after you leave grant and per diem, sometimes people will enroll in another program and they'll get temporary rental assistance, for instance. And then finally, in the last two columns, I'm going to look at the cost of medical care. This is based on the VA's Health Economics Resource Center. So they're going to do cost accounting using very detailed procedure codes and then attribute those to costs based on Medicare reimbursement rates. Yeah. So, okay, I could add a value of statistical life if we assume any reasonable value of the statistical life, like, you know, anywhere from 1 million to 10 million, the benefits are far going to exceed the cost. But this was just to illustrate that a lot of people think that transitional housing is going to be much cheaper than housing first, and that's not what I'm finding here. But if I do any cost benefit, I would also get a similar conclusion. So in terms of outpatient costs, you can see that the grant and per diem program increases outpatient costs by quite a lot more. A lot of this is coming from the mental health, increase in mental health visits that we saw before, as well as some physical health visits as well. And then this is kind of the main surprising finding, which I can show you in another presentation. I'll add the intermediate results on inpatient lengths of stay. But essentially what I'm finding is that housing first causes a big decline in inpatient mental health lengths of stay. So these are primarily like residential rehab programs for substance use and programs like that. And enrolling in the voucher program increases your length of stay in one of these programs by about 12 days over the study period. And this translates to a cost savings of around $10,000. So overall, if we add these columns up, we see that over the 3 years, at least over the 3 years that I can observe it, HUD-VASH is going to be cheaper than the transitional housing program by about $10,000. Yeah. Yeah, so one, you could say that potentially these would be higher in the long term because this is just over 3 years, but it's because grant and per diem is actually very expensive per day. And that's because, you know, there'll be these sites where there's social workers on site and potentially psychologists on site. There's much more services. Whereas for HUD-VASH, like the average cost of the voucher for a month is about like $580. So actually per day, it's much cheaper, even though they're staying much longer. Yeah. Okay. All right, I think I'm out of time. So in conclusion, this study was the first to show that housing first reduces mortality. And I also showed you that housing first far outperforms treatment first type interventions in terms of long-term housing stability, health outcomes, as well as costs.
Thank you, Sydney. We have one more paper today. It will begin in 15. Great. Thank you so much for your participation throughout the day. We're very thrilled to have our last presentation of the day, Juliana Londoño Vélez. Though you have first 5 minutes completely uninterrupted.
Thank you. I'm Juliana, and I'm going to talk about what are the consequences of abortion denial on women's physical and mental health. This is joint work with Estefania, who's a phenomenal PhD student at UCLA. So the motivation is that restrictions on access to abortion continue to be the subject of intense policy debate in many countries. In the United States, following Dobbs, major medical and psychological associations warned that restricting access to abortion could harm women's physical and mental health. And despite these high policy stakes, we actually know very little about what are the long-run consequences of restricting access to abortion on women's health. And there are two main reasons for this. One is measurement. How do you even identify women who want to have an abortion but are denied access? And second is how do I identify causal effects, since women who are denied access may systematically differ from those who eventually access abortion. The best evidence to date comes from something called the Turnaway Study, in which a group of around 1,000 women who were wanting to have an abortion, some of them are denied access, they were tracked over time. And researchers found that abortion denial substantially worsened women's economic outcomes, and yet it produced no detectable long-run impacts on their physical or mental health. And so we might think that this null result could be surprising in light of the evidence that socioeconomic conditions can impact people's health. And so we may think that the small sample, implies that this study may be underpowered to detect precise estimates or estimates on uncommon but clinically important health events. And so this leaves us with the question that motivates this paper, which is what are the long-run causal effects of abortion denial on women's health? And that's exactly what this paper is going to try and do. And the setting for this is Colombia, where abortion is legally permitted, but there are barriers to access that remain widespread. Some women are going to challenge these barriers by filing a constitutional writ called a tutela. And I'll explain how it works in just a few slides. Our data consists of more than 100,000 abortion-related tutelas that we link to nationwide longitudinal administrative health records encompassing the universe of healthcare encounters in the country. And to identify causal effects, we use a judge leniency design that exploits the fact that these tutelas are randomly assigned to judges, and the fact that judges vary significantly in their propensity to deny abortion requests. On average, roughly half of cases are denied. And so to summarize our main results, we find that abortion denial produces a large and a persistent deterioration in women's mental health, reflected in both clinically verified conditions as well as psychotropic medication use. For example, the likelihood of being diagnosed with a mental health condition increases by 26 percentage points on impact, which is roughly 8 times the baseline rate. And both diagnoses and medication use remain elevated years later. Our second result is that abortion denial causes a persistent deterioration in women's physical and reproductive health. We see persistent increases in reproductive morbidity and reproductive infections, in emergency department visits, in hospitalizations, and ultimately a higher death rate. These health harms increase sharply with gestational age. And so overall, we conclude that abortion denial causes a large and a persistent deterioration in women's mental, physical, and reproductive health. We see these results as making several contributions to the literature. As I mentioned, the closest evidence comes from the Turnaway Study, which found no persistent differences in women's mental or physical health as self-reported through a survey. And so in addition to the small sample problem that I mentioned before, the researchers are also relying on self-reported health. In previous work, Estefania and I focused on a single city in Colombia called Medellin, and we found that abortion denial increases mortality and it worsens women's physical health, again, as self-reported in a survey. And so in this paper, we make 2 advances. First, we're going to use nationwide administrative records covering more than 100,000 women seeking abortion. And this large sample enables us to estimate precise effects on even relatively uncommon health outcomes. Second, rather than relying on self-reported health, we're going to use clinically verified outcomes, including diagnoses, redeemed medications, emergency department visits, and hospitalizations. And together, these two advances allow us to provide what is, to our knowledge, the first comprehensive causal evidence on the persistent mental, physical, and reproductive health impacts of abortion denial. This is great because I'm out of time, and so we can now have, if you have any questions, I'm free to start taking them. Yes?
Especially, I started thinking, especially when you were showing some of the results on physical and reproductive health, it seems like there's the contrast you're doing, which is interesting, is being denied an abortion versus being allowed an abortion. There's potentially another contrast you could have, which is to having a child not having attempted an abortion. And I was wondering if you'd thought about that as a contrast group.
Yeah, I mean, so we have, so I'll get a little bit to that because abortion denial substantially changes people's pregnancy outcomes, since that's actually one of the results, the first result that I'll find. And for some women, it will increase their likelihood of carrying the pregnancy to term. And for others, it will lead to another outcome. And so we can talk about that and potentially compare outcomes. Yes. Okay, so what I'm going to do is I'm going to describe the background first and the data that we're working with. So before 2006, Colombia criminalized all abortions without any exception. In 2006, the Constitutional Court rules that a total abortion ban is unconstitutional, and it's going to allow abortion. There's three circumstances. One is when there's a severe fetal abnormality incompatible with life. Two, when the pregnancy is the result of a rape or incest. And three, and this is the most important, when the continuation of the pregnancy threatens the woman's life or her physical or mental health. And so under these broad clauses, the Constitutional Court rules that there are no gestational age limits. And insurers and providers are required to provide timely access to abortion free of charge. Now, after our study period, which is more recently in 2022, Colombia further liberalized abortions by allowing abortions on request after up to 24 weeks of gestation. That's beyond our study period. So we're very much in this first scenario, okay? And so the crucial point is that despite these broad clauses and these legal protections, they do not guarantee access to abortion. And the reason is that because abortion continues to remain criminalized under all other circumstances, many providers are going to continue to refuse to perform abortions by either invoking conscientious objection based on religious ground, which is constitutionally protected, or misapplying abortion law by, for example, imposing unlawful gestational age limits or disregarding risk to the woman's mental health. Health insurers, who in Colombia are responsible for coordinating care, are also going to delay or deny access by, for example, requiring unnecessary documentation, failing to connect women with willing providers, or outright demanding judicial approval, meaning telling the woman that I need a judge to tell me that this specific abortion would be legal under the law. And so for these reasons, many women are going to face delays or outright denials of abortion care. And the tens of thousands of them are going to try to protect their constitutional right to an abortion by filing a tutela. We see that nearly 1 of every 3 recorded induced abortions occur after filing a tutela, which indicates that tutelas have become a major pathway to abortion care during this period. And so how exactly does a tutela work? So a tutela is a fast-tracked constitutional remedy that is designed to protect fundamental constitutional rights when their delay would cause irreparable harm. It is designed to be accessible, so it is free. It requires no legal representation. There's no lawyer involved. And it consists of a simple written petition in which the person, in this case the woman, explain which is the right that's being threatened and who is threatening it. And the judge has to make a decision based on that written petition with no court hearings, no direct interactions with the claimant. Now, this is great for us as econometricians because it means that we observe essentially the same information as the judge. The process is expedited, so the judge has to make a decision within 10 days, and their decision is basically you either grant the request, deny it, or dismiss the case as inadmissible. And the judge decision is immediately enforceable, so noncompliance can trigger fines or even imprisonment. And what's crucial for us is that cases are quasi-randomly assigned to judges through the country's reparto system, which is meant to guarantee an equitable distribution of caseloads. One second, Zarek. It's designed to promote transparency in the system and prevent judicial corruption. And so what this means for us is that a woman cannot choose a judge that's going to be assigned to the case, and a judge cannot choose which cases to take on or not. Yes? So it both. We see that in our case, 2/3 of the tutelas are going to be naming the insurer as the one who's violating the right. I mean, yes, in principle, it's a judge. I mean, it's interesting. We could see that if a person puts more than one tutela. I don't think so. It's mainly just one. And it's the insurer's responsibility to connect the woman with the provider. Yeah, interesting. We could think more about it, for sure. Yes. Yeah. No, it's the same process. You can, if a minor can file a tutela, if not, you can have a person file for you. Yeah, I believe so. On average, the women in our sample are going to be around 24, 25 years old. No. Okay, so because judges vary substantially, as I'll show you in a few slides, in their propensity to deny abortion requests, and roughly half of cases are denied, whether a woman is denied an abortion is very much close to a coin toss. Okay, so our data consists of 3 different linked administrative data sets. We start with the universe of abortion-related tutelas filed in the 4 largest judicial districts of Bogotá, Medellín, Cali, and Barranquilla from 2011 to 2022. The data includes the name of the assigned judge, the ruling, which is accept, deny, etc., and then the claimant identifiers. We then link that information to nationwide longitudinal administrative health records that cover the universe of healthcare encounters in the country. This includes all outpatient visits, medical procedures, or emergency department visits and hospitalizations. The records also include clinically verified diagnoses coded using 4-digit ICD-10 codes, as well as redeemed medications classified using ATC codes. We then link that to nationwide vital statistics covering the universe of recorded births and deaths in the country. And the fact that we're linking this information at the individual level means that we can track women over time before and after requesting an abortion. And so before I describe the research design, let me briefly describe the study sample. So our data consists of more than 100,000 women who seek abortion through tutelas. Among this sample, the overwhelming majority, 85% of them, have never had a documented mental health diagnosis before filing for abortion. Keep this in mind when you see the impacts on mental health later. We're able to infer gestational age for about 2/3 of the sample, and among them, most women will file in their first trimester, 55%, 45% will file later. I will come back to this because gestational age turns out to be a really important predictor of treatment effects. So our empirical strategy is going to consist of comparing outcomes for pregnancies that are assigned to judges who vary in their propensity to deny abortion. So our data consists of 108,000 cases that are decided on by 1,773 judges. These judges differ substantially in their propensity to deny abortion requests. This histogram plots the judge leave one out stringency measure. We see that, on even though on average, half of cases are denied, there's a widespread. The difference between judges at the 90th percentile and 10th percentile of the distribution is 35 percentage point. And so we're going to leverage this huge variation in propensity to deny abortion in our research design. So I guess the first question is, does judge stringency predict likelihood of being denied abortion? And the blue line shows that it does. The relationship is very strong and it's remarkably linear. It tells you that being assigned to a more stringent judge increases your likelihood of being denied abortion nearly 1-for-1. The Wald F statistic is above 8,000. Yes. So it's not required to report the reason why you're requesting an abortion, although it's in your interest to do it. So among the sample that we do observe, we actually see that denial rates are very, very similar. We haven't done more beyond that, but we could think more about it. Yes. Yes. The quality of, excuse me, the quality of what? Yes, for sure. Absolutely. So I can tell you a little bit about it. If you don't cite the reason, you're more likely to be denied, okay? Because the judge basically has no information to decide whether to make a decision. And of course, that means that then being denied is obviously not random. And it's going to be correlated with your characteristics, correlated with the quality of the written petition. And so we see that more vulnerable women, poor women, younger women tend to be denied on average, which actually is why we need to use the judge stringency as an instrument. And so getting back to that judge stringency as an instrument, we're relying on quasi-random assignment of cases to judges. And so let me show you some visual evidence of that. We are going to predict the likelihood of being denied abortion using all observable covariates, and that's the horizontal line. We see that the predicted denial rate is essentially a flat across the full support of the instrument, meaning that observable characteristics do not predict assignment to a more stringent judge, as would be consistent with random assignment. In the paper, we show additional balance tests, all of which support the same conclusion. And so we use this intuition in our judge leniency design that exploits this random assignment and the substantial variation, the propensity to deny abortion among judges. The first equation is the first stage, which is basically whether the case is denied and how that varies with the judge leave one out, judge denial propensity, and judicial district by office by quarter fixed effects. And then the second equation, we're basically going to compare outcomes for pregnancy I and quarter T, depending on whether the case is denied or not, and then instrument that with the judge stringency measure. Throughout the paper, we use the unbiased jackknife IV estimator, or UJIVE, which solves some of the potential small finite sample bias that can occur when you have many instruments. However, when we use the conventional leave one out judge stringency measure, the effects are essentially identical. In the paper, we also report some evidence supporting the exclusion and monotonicity restrictions, and we report the characteristics of compliers. Unless anyone tells me that I should click on those buttons, I am going to, okay, that's a no, great. So I'm going to move forward because Urso said I could do it. Okay, so now to look at the first outcomes, let's start with the question that Amy posed, which is how does abortion denial affect pregnancy outcomes? And so the first question is, like, does the judge decision actually matter? Let's start there. And so we're going to first look at what is the effect of being denied abortion by the judge on the likelihood of on the cumulative likelihood of you ever getting a recorded induced abortion. And we're going to compare outcomes over time. So on the y-axis, I have the UJIVE estimates. And on the x-axis, I have the quarters since the moment you filed a tutela. And so I'll stop here and say that this is not an event study. It looks like an event study, but it is not an event study. Each estimate is a separate UGIVE estimate with 95% confidence intervals. Before filing, a year before filing, only 1% of the sample had ever had a recorded induced abortion. Then there were no systematic differences between denied and non-denied groups. After filing, abortion denial reduces the likelihood of ever obtaining a recorded induced abortion by 47 percentage points. And this effect remains very, very similar even 3 years later, which tells us that abortions prevented in the filing period are not simply showing up later in administrative records. And so overall, we see that within 9 months from filing, the likelihood of you getting a recorded induced abortion drops by 50 percentage points. So how are these pregnancies being resolved? We see a corresponding increase in the likelihood of carrying the pregnancy to term. So being denied abortion by the judge increases the likelihood of having a live birth by 21 percentage points. You'll notice that then it's interesting because it means that fewer than half of prevented abortions are resulting in additional births. Instead, we see an increase of 28 percentage points in an other pregnancy resolution, meaning these are pregnancies that are being resolved not as recorded induced abortions, not as pregnancies, not as fetal death. And so it suggests that we may be in a setting where many women are resolving their pregnancies outside the formal health system. Okay, with that, let me move on to mental health. So we're going to start by looking at what is the effect, yes. We see procedures, we see diagnoses, but what do you have in mind? Yes, and I'll look at that later. Yes, I can look at subsequent pregnancy outcomes, absolutely, yes. And in fact, that's gonna be some of the, I'll look at that when we talk about mechanisms a little bit, yes. So I'll show you those results. Any other question? Okay. Okay, so let's look at mental health. So I'm going to show you what is the impact of being denied abortion by the judge on the likelihood of you being diagnosed with a mental health condition. A year before filing, only 3.5% of denied women have such a diagnosis. And this likelihood goes up by nearly 26 percentage points. That's roughly over 8 times the baseline mean. And the effect remains significant even 3 years later at 0.5 percentage points. Yes. No, this is no. So I can show you ever diagnosed here. Yeah, so that was a quarterly likelihood, and this is the cumulative likelihood of ever receiving a mental health diagnosis goes up by 20 percentage points. Yes.
Pregnancy, which was actually charitable of you. That was you turned my question into a subtler question than I had meant. I guess all I had meant is, obviously there are many potential downstream consequences of being denied an abortion, not all of which are mediated through having the birth.
Yes.
But if I held that aside for a second and thought, this is all coming from the, 20% who have a birth, what do the mental health consequences of, having a child if you did on similar covariates look like? That's what I was just, and same for the other outcomes. That's what I was just
yes,
trying
so
to think.
that specific comparison, we haven't done it. It's on our to-dos list. We could do, we could see what is, how is mental health changing before and after you have a kid, and how does that compare to the impacts we see?
Adjusted on X's for a similar population.
Yeah.
Exactly. I would just be curious.
Yeah. We could check. I'll just say we looked, this is not exactly an answer, but we did look at postpartum, and it doesn't seem to, these effects are just so much larger, but we should definitely look at just any mental health condition before and after having kids as a comparison. Okay, so what exactly is happening? What exactly are these diagnoses? This is all coming from increases in depression and anxiety, which go up and remain significant 3 years later. So that was a mental health diagnosis, but when we look at psychotropic medication use, it shows a very similar pattern. The likelihood of redeeming psychotropic medication goes up by nearly 7 percentage points on impacts, and it remains large at 1 percentage point 3 years later. Yes. Absolutely. We have not broken it down. This is any psychotropic medication, but it does mean, to your point, that because many women are remaining pregnant, it's an underestimate, right? Because they will be taking medication during pregnancy. But to compare this point estimate over here to the literature where it's pregnancy is at 3 years later now resolved, this estimate or the effect of abortion denial on psychotropic medication use is much larger than the effect of losing a parent. It's similar to the effect of losing a spouse or infertility, and it's slightly smaller than the effect of rape. We also see that abortion denial increases the severity of mental health treatment. The likelihood of you redeeming antipsychotic medication goes up by more than 4 percentage points and remains large 3 years later. We also see increases that persist over time in the likelihood of having a consultation with a psychiatrist. Okay, moving on to impacts on physical and reproductive health. Let's start with reproductive infection. So the series in gray plots the likelihood of you being diagnosed with a direct infectious complication of abortion. Because abortion denial by the judge prevents abortion, the likelihood of being diagnosed with infection caused by abortion goes down. Except that if you look at all other infections, that goes up on impact and it remains significant even 3 years later. This is driven by genitourinary conditions and reproductive infections. When we look at the series for antibiotics, which are presumably to treat infections or systemic antibiotics, so it's a very similar pattern of increase on impact that remains large and significant 3 years later. Yes. Yes. So I think part of this is because 45% of women are filing in their second and third trimester. By the time they access abortion, which is roughly 3 weeks later on average, you're looking no longer into medicated abortions, you're looking into surgical procedures, which have a higher complication rate. Yeah. Okay, but the effect on physical and reproductive health go beyond just infections. We also see impacts on reproductive morbidity, the effect of abortion denial on the likelihood of being diagnosed with pain or reproductive morbidity go up and remain higher even 2 years later. The diagnosis, when we look into these diagnoses further, it's coming from pain in the lower abdominal area and pelvic area, as well as menstrual and gynecological conditions. Yes, Eric, I see you being very confused. It could be, and we're actually going to look at these conditions over time, and we see that they persist among a population that will have a second pregnancy. And so I'll show you those results later, but it's not only driven by that. Yeah, I think we could do some benchmarking. We could do benchmarking relative to childbirth. We could do a benchmarking relative to the average pregnancy. Yeah, for sure. Okay, when we look at redeemed analgesic prescriptions, it shows a very similar pattern, an increase, and then that remains significant 2 years later. Turning now to acute health care and mortality, we're going to look and see whether these persistent increases in reproductive infections and morbidity translate into a greater use of acute health care. And the series on the left plots the likelihood of you visiting the emergency department in a given quarter. The figure on the right shows the likelihood of you being hospitalized in a given quarter. Let's start with the series in gray. Abortion denial by the judge reduces the likelihood of you visiting the emergency department or being hospitalized. But this is again almost mechanical because many abortions require hospitalization and they pass through the emergency department. So when we exclude these encounters that are occurring on the day of the abortion procedure, as we do in black, that eliminates this initial decline. Instead, what we see is that abortion denial increases the likelihood of you visiting the emergency department and being hospitalized 1 quarter later, with the effects remaining large and economically meaningful 3 years later. So that, 12 quarters after filing, your likelihood of you visiting the emergency department that quarter goes up by 6.7 percentage points. Your likelihood of visiting or being hospitalized has gone up by close to 4 percentage points. So the very large impact on acute healthcare utilization. In fact, what abortion denial also does is that it increases the cumulative burden of acute healthcare utilization. So what are people being diagnosed with, 12 quarters later? So what this next figure is going to do is decompose the diagnosis made 12 quarters later during the ED visits and hospitalizations by ICD-10 chapter. And what we see is increases in genitourinary conditions, symptoms, signs, and pain, and infectious diseases, with the very similar result for hospitalizations. So this is consistent with the evidence that I showed you before, which is that we see persistent increases in genitourinary pain and infection caused by abortion denial, and that also reflects, 12 quarters later in acute healthcare utilization. Yes? 12 quarters later, it includes any hospitalization. Yeah, maybe so. Actually, yeah, maybe that explains why there's a slight reduction, because this may be labor and delivery. Yeah, by quarter 3, all pregnancies should be resolved. Okay. Yes. For voluntary births? Oh, how does this compare to the effects of just giving birth? We could also do that. We have not done that. We should just benchmark everything with the effect of childbirth, for sure.
But then we'd complain that, I want to see it, but then you'd have to caveat it that you don't have an instrument for an unwanted birth. It's also potentially, the effects of getting an illegal abortion.
Right.
Or an abortion through some other means. Yeah.
Yeah. Yeah.
Still, I think it would just be a useful,
Yeah.
not like a literal causal comparison, but just a useful benchmark.
Absolutely. Absolutely. I hear you. Okay. So this, basically the conclusion from this slide is that the increase in acute healthcare utilization isn't broad-based. It is driven by persistent increases in genitourinary conditions, pain, and infectious diseases, consistent with the prior evidence I showed you before. So then the next question is, does this result eventually in a higher mortality for this population? And indeed, we see that it does. The likelihood of you dying based on death records within the 9 months from filing for abortion increases by 0.5 percentage points, for 5 additional deaths per 1,000 women. And it's all driven by mortality from septicemia and infections, with mortality from all other causes remaining essentially unaffected. So overall, what this is telling us is that abortion denial can have severe and in fact sometimes fatal physical health consequences. So to conclude, and putting all of the evidence together, we find that abortion denial causes a broad spectrum of persistent health consequences. Abortion denial causes a large and a persistent deterioration in women's health. On the one side, it causes a persistent mental health deterioration as measured by mental health diagnoses and redeemed psychotropic medications. It also causes a persistent deterioration in women's physical and reproductive health as measured by reproductive infections and morbidity, emergency department visits and hospitalization, and ultimately also mortality. Now, these effects do not necessarily occur sequentially or among the same type of women, but they do reflect the breadth and severity of the health consequences of abortion denial. Yes. Yeah, no, exactly. So thank you for that question. You want to have a documentation because the law says you need a mental health risk to be certified by a psychiatrist. The filing, by the time of filing, you need to attach those records. So filing at that point, you should have had documentation. Now, of course, you know, but so yes, so the moment of filing at that
The
point.
question is your 0-1 quarter all after filing?
After filing, exactly. It's after filing, yes, immediately after filing. It's the post period. Excuse me? Yes, and so, but we use the judge stringency as the instrument. Indeed, if we did that otherwise, then yes, absolutely. Yeah, yeah. Yes. No, no, you didn't miss it. Yeah, so there is an appeal process. 10 minutes, okay. There is an appeal process. 14.9% of women appeal. And among those, only 0.5% of cases are switched from denial to non-denial. So overall, it's like a tiny, tiny fraction of overall cases are switched by the judge. Yes. Yeah.
I go to the doctor or some of the doctor and request a abortion.
Yeah.
And for they have a right.
Yes.
Go to another doctor, like
So that's rare in our setting because 2/3 of women, as 2/3 of Colombia, are in the subsidized healthcare system, so you don't have a lot of choice. However, you are pointing at something, which is that when we compare our sample to all women who are having recorded induced abortions without filing tutelas, the two samples look very different. Women who access abortion without this tutela process are just more socioeconomically advanced. They have everything is, you know, more they're just wealthier, etc. So yeah. But however, if we, I think the fact that nearly one of every three abortions are occurring through this process means that it's kind of important. Right, that's not really our setting. There's much less shopping for doctors, yeah. Yes.
Which I know you don't have a paper for that, or because they carry the pregnancy there. It can be one.
Yeah. So we could in principle just compare mortality impacts by whether or not you carry the term or not. But mortality is such a rare outcome that when we start doing heterogeneity analysis on a very rare outcome, there's not much I can say. Okay, so I have like 8 minutes left. So I want to move forward and tell you, okay, so I showed you the average effects. The next question is whether these effects are concentrated among a particular group of women. And I guess we can start with the question is, where are the health harms largest? And the evidence here is very clear. The health harms increase sharply with gestational age. So women who are filing and being denied later in their pregnancies are the ones who are suffering more in terms of their mental health. They're also the ones that are coming 3 years later to the emergency department and being hospitalized. Another question is, who bears the mental health burden of abortion denial? And so here we're going to compare impacts by whether or not you had a pre-existing mental health condition or a diagnosis. And we see that indeed, women who had a mental health diagnosis at baseline suffer more in terms of their mental health from abortion denial than those who don't. However, because remember, fewer than 15% of women had a prior mental health condition to begin with, the overwhelming majority of the mental health burden falls on women with no prior mental health condition. And so rather than merely exacerbating pre-existing conditions, abortion denial is causing substantially new mental health problems among a population that didn't have them to begin with. In the paper, we also show additional heterogeneity analysis by comparing women by their prior parity, by their prior contacts with a primary care physician, by the health regime, and by the legal grounds invoked in the tutela to request an abortion. And by and large, we see that abortion denial has substantial health harms across all subgroups. Lastly, in the last 5 minutes, I think I've got, we ask, why do these health effects persist? And we consider two competing explanations. One is that women are changing, abortion denial induces women to change their behavior by either, as some people say, increasing their use of contraception or changing their subsequent pregnancy, which one of the questions that came up. The evidence is not consistent with this. In fact, we find no sustained increase in contraception. If anything, abortion denial reduces contraceptive use. We also find no long-run reductions in subsequent fertility. Instead, yes. Well, so in the first 3 years, the likelihood of having another pregnancy does drop because you had a pregnancy, and so yeah. But overall, when we look at the likelihood of you ever having a subsequent pregnancy, it's a very precise null. Yeah. And so then we considered an alternative explanation, which is that abortion denial causes a lasting deterioration in reproductive health. And here's where we find evidence that is consistent with this. We find that abortion denial causes worse subsequent pregnancy outcomes, including a higher risk of an ectopic pregnancy and a higher risk of fetal death. We also see that the persistent reproductive morbidity is higher among women with subsequent pregnancies. Yes.
Long run effect on subsequent fertility.
Yeah.
I wondered what would happen if you split it by the number of children they'd already had, in the sense of, I don't know enough about Colombia, but in the US, maybe people have a target of 2 kids. And so there could be is it about changing the timing for people who hadn't yet had their target number of kids versus, people who already had 2 kids? I would have thought it would have a long run effect on total.
I could click. I think we have that result, but I don't think we have it in these slides, but we could look at that for sure. We could look at that. Okay. And so overall, what this part of our paper suggests is that the reason why the health effects persist is because abortion denial leaves women less healthy, not because it changes their reproductive behavior permanently. Okay, so I have like 3 minutes left, and so let me briefly conclude. So what we've done is we've leveraged large administrative data and quasi-experimental variation in abortion denial, and found that abortion denial causes a large and persistent deterioration across the full spectrum of women's health, including their mental, physical, and reproductive health. We find that the health consequences of abortion denial increase sharply with gestational age, but they remain substantial across all groups. And lastly, we see that we find evidence consistent with the idea that the reason why these health effects persist is because abortion denial leaves women less healthy rather than changing their reproductive behavior. I think I have like a minute for questions, so I'd be happy to take David. Yes.
Why did you use that here, and how the result different?
Yes, thank you for asking that. In that initial paper, we started out with Medellin for no other reason than Estefania was from Medellin, and we said, okay, we need a large city. And we found this huge sex gap between the likelihood of denying abortion between male and female judges, 20 percentage point gap. We said, okay, great, so we can use judge sex as an instrument. And in the paper, we showed robustness with using the leave one out stringency measure. When we started expanding the analysis to the entire country, we found a second result, which is that the sex gap varies a lot across geographic areas. So it's large in some cities, including Medellin, and small in the capital city of Bogota. And so that leads to a different paper that we want to write, which is like what shapes men's attitudes towards abortion. But in this paper, we said, okay, well, let's exploit the large variation that we see, and we use the judge stringency measure and show robustness using other stuff in the appendix. Yes.
Thanks for bringing that up, because I found that first stage result of your previous paper just separately hugely fascinating. It's even more fascinating that it sort of varies. I would just so I'm glad you're writing the follow-up paper. I would add the gender thing is obviously first order and fascinating, but just more generally, what predicts attitudes towards abortion
Yes.
and what shapes them. And
Yes.
yeah, it's super
Yes.
fascinating.
Yeah. I think I have time for one last question.
Women who are denied abortion getting a non-medical abortion. Can you mention that at all?
Oh, I thought I did. I showed that the likelihood of a residual pregnancy outcome, meaning pregnancy being resolved not as a recorded induced abortion and not as a live birth, goes up. We infer that that's partly informal abortions. Yeah. So, okay, so someone has asked that before, so let me just click on this slide. So the subsequent pregnancy outcome is endogenous, okay? So take everything with a grain of salt. What I'm doing here is I'm showing heterogeneity by whether or not you carry the pregnancy to term versus not, which we're gonna infer that it's informal abortions. And this is what you see. So we see slightly larger effects for the residual, but they're clearly not zero for women who carry the pregnancy to term. Women in the residual group seem to have larger and greater increases in their infection rate. But again, this is endogenous, so it's like hard to make too much of it. Okay, I'm out of time. Thank you so much.
Thank you, Julia. Thanks everyone for a great first day. We reconvene tomorrow morning at 9:20 a.m. If you are on the program for tomorrow and you have your slides, why don't you take a moment to upload them now?